Baba and Dr. Kaushal, the IAP EB members from Delhi. So welcome everybody, and wishing all the best, Dr. Dinesh and dear Hema, for the successful module of completion today. Thank you very much.
Thank you very much, sir, for such a nice words. And now I request our Secretary General, Dr. Basuraj sir, to speak on MCA.
Yeah,
Dr.
good afternoon
Basuraj.
to all. Respected our visionary President, Dr. Bakul Jayant Parikh, sir, and President-elect, Dr. Piyush Gupta ji, and North Zone Vice President, Dr. Anand Vasudev. First of all, let me congratulate IAP North Delhi trio, Dr. Dinesh, Dr. Hema Gupta, Dr. Shalini Gohel, under the guidance of Delhi President, Dr. Ramesh Nath, Smita Mishra Madam, with our Executive Board member, Dr. Alok Bhandari ji, GP Kaushal, Devender Gaba, for organizing this wonderful COP workshop, which is very, very relevant in day-to-day practice. And I'll take this opportunity to congratulate our IAP Respiratory Chapter President, Dr. Jagdish Chinnappa, and our Dynamic Secretary, Dr. Subramanya, N.K. Subramanya, and Professor S.K. Kabraji, with other writing committee member, for coming out within a beautiful module, which is very popular across India, which is the most sought module. Thank you, Dr. Subramanya, for this wonderful this one. So I take this opportunity to welcome all our participants who are logged in. Wish you happy learning. Thank you. Wish you all the best for this workshop. Thank you.
Thank you, sir. So now I request our IAP Delhi President, Dr. Ganesh Nath, sir, who is also a co-host of this conference, to say something, sir.
Sir,
Dr. Nath.
Greetings from IAP Delhi, sir. Respectable Bakul Parikh, sir, and the dynamic Baswaraj, Secretary General of Central IAP, and Dr. Vasudev, the National Vice President of Central IAP and Central IAP, all the EB members, and National Respiratory Chapter dignitaries, and Dr. Dinesh Mittal, Dr. Shalini Goel, Dr. Hema, and Dr. Smita Mishra. I really bring greetings from IAP Delhi, and we, along with IAP North Delhi, have joined hands with National Respiratory Chapter for this e-cough module camp. And the topics concerned are really of great importance to the general pediatricians, and they'll be of great help in their regular day-to-day practice. And I wish all the attendees happy learning. And I must congratulate the entire team, organizing team, for arranging this workshop. So very grateful to you all for this inauguration. Thank you.
Thank you, sir. Thank you, sir. I request Dr. Smita Mishra, the Secretary IAP Delhi, to say something.
Good afternoon, everyone. Respected Bakul Parikh, our very dynamic and visionary President, Central IAP, Dr. Piyush Gupta, the President-elect, Dr. Basuraj, Dynamic Secretary of Central IAP, Dr. Vasudev, Vice President, and Respiratory Chapter dignitaries, Dr. Chinnappa, whom I am meeting after such a long time, Dr. Subramanyam, Dr. Kabra, and our CIAP member, Dr. Alok Bhandari, Dr. GP Kaushal. This is all on behest of Dr. Dinesh Mittal and Dr. Shalini Goel, as well as Hema Mittal. They make a trio of the Delhi IAP activity. Dr. Ramesh Nath remain the great inspiration. He actually drives us to be together and keep on doing the good thing and good interactive sessions. So thank you very much, sir, for being such a inspiration for all of us. Congratulations, Dinesh. Congratulations, Shalini. Congratulations, Hema, for this particular program and the respiratory chapter. Thank you.
I'm extremely sorry I missed out on Professor Piyush Gupta ji. I missed out his name. I greet him from IAP Delhi side. Please, Dr. Piyush Gupta. Somehow, you suddenly skip. I'm extremely sorry for that.
No
thank
issues,
you.
sir. Thank you so much. Thank you so much.
Sir is always special, you know.
Sir, I am always in your heart, so never feel that I have been missed. I am never missed. I know that. Thank you.
Okay.
Thank you, ma'am. Thank you, ma'am. So now it's time to uh, invite Dr. Jagdish Chinappa, sir, who is the President, National Respiratory Chapter of IAP, to say something. Although he's the man behind all this activity, but I request him to say something about it.
Thank you very much, sir, for those kind words. At the outset, I bring greetings from the respiratory chapter. We are honored by the support given to us by the Central IAP, Dr. Bakul Parekh, Dr. Piyush Gupta, Dr. Basavraj, Dr. Vasudev. Dr. Vasudev has been supportive of all our programs for many years. Of course, all this is under the guidance of very senior people like Dr. S.K. Kabra, who's been the leading light of the respiratory chapter for many years. We are very happy that this module on cough has been developed by many of the pediatric pulmonologists from the Northeast and from Orissa and other places. So you will see a different flavor of respiratory medicine coming out in this particular chapter. This is under the leadership of our dynamic secretary, Dr. Subramanya, who has worked night and day to make this module a success. I thank the Delhi team for allowing us to host this in Delhi with such a massive participation with almost 600 delegates. I thank Dr. Dinesh Mittal, Dr. Shalini. Dr. Hema has been supportive of all our programs and she's been participating in many of our activities. And old friends, many of whom are here, Dr. Smita Mishra, Dr. Alok Bhandari, and Dr. Ramesh, all of you, thank you so much for allowing us to host this in Delhi. And we look forward to a very interactive session so that we can build upon this and bring more and more programs and more activities to different parts of the country. Thank you so much for allowing us to host this today. So I remain, thank you so much.
Thank you, sir. So now invite Dr. Jagdish Chinappa, sir. He's one of the best administrator as well as speaker also. I attended his TOT and I really enjoyed and learned so much from him. I request Dr. Jagdish Chinappa, sir, to say a few words. Sorry, sir. Subramanyam, sir.
Okay.
Subramanyam, I'm really sorry.
No.
Yeah.
Thank you, Dr. Dinesh. At the outset, let me thank our mentors, Dr. Bakul, Dr. Piyush Gupta, and Dr. Jagdish, and my very close friend, Dr. Basavraj. Many times I forget him as secretary. Now we have been together in Karnataka for such a long time. So with the most hardworking secretary I have ever seen. The team Delhi and many of my colleague EB members I am seeing.
Hello.
And Dr. Vasudev, Dr. Alok.
अरे सर मैं तो भूल गया वो shit. So sorry sir. So sorry. Now एक second.
I'm not taking all the names. The team Delhi and young leader from pulmonology have given to us Dr. Hema. She's involved in many of our modules, and the doyen of the chapter, and I don't think I should name him. He has more publications than the membership strength of the chapter by number. Dr. Kabraji and every one of you from the respiratory family. So at the outset, this concept was to rationalize the approach and management of acute, recurrent, and chronic cough from a symptom approach to diagnosis to therapeutic challenges, prevention, and everything. This would be made in the form of a recipe that you can really enjoy better than your meal today. So those of you are hungry, you can mute yourself and enjoy the sessions. And those of you are awake can join us in discussions. We will not spare any one of you from interaction. So this module is mainly designed in such a way that there is maximum interactions. I would wish that I would take the names of all 600 of you, plus who have registered, but time does not permit, would be. every one of you practice respiratory medicine. There is nobody who doesn't practice respiratory medicine. But just for a minute, introspect and think, are you a member of the chapter? If not, today we will not allow you to log out of the session without filling the application form for membership. So I would be watching on the chat box. Please type. If you're not a member, I would send a link. Right now you can become members. But let me, last word from me, I would thank the authors from the Northeast, Dr. Partha and team, Dr. Shitanshu, and many more who have contributed to the chapter in write-up. So it was just in 15 days. We have the team has worked more than 26 hours for given 24 hours to see that this module is realized. And it is perhaps in my, at least in my memory, this is one of the most popular modules which I can see in my generation. I don't know. So it is catching up like wildfire. It is spreading more than COVID. So let's see how far we can reach out to you. And thank you very much.
Thank you, Subramanian. I request Dr. Anand Vasudev sir. I am extremely sorry. You should have spoken just after the National Vice President and the President-elect as per hierarchy. I'm really sorry. I'm extremely sorry that I forgot. I request Dr. Vasudev sir to address this gathering.
Thank you, Dinesh. No issues, no worries. It's such a large platform. Sometimes you are not able to see people, and then you tend to forget. But this is all in the at home only. And I can bring my greetings from Central IAP and also from Delhi, which is my home state, to all the members who are here for this wonderful module on cough. As already spoken, it's a very common entity. And I welcome our national Central IAP dignitaries, Dr. Bakul Jayant Parekh, Dr. Basavaraj, Dr. Piyush Gupta, and all the EB members from the Central IAP, with the dignitaries from Delhi IAP, North Zone, North Delhi, all the members from North Delhi, and our eminent faculty, especially Dr. Chinappa, Dr. Subra, who have joined us all the way from Karnataka. And I say you have come all the way from Karnataka to Delhi to join us. And Dr. Kabra, of course, who is a part of us in Delhi only. IAP Delhi has been doing wonderful work, and the North Delhi, especially we see that under the leadership of Dr. Dinesh Mittal, who is excellent dynamic worker, very happy and a very smiling person and ever helping. In my North Zone Web Week, I know how much trouble I would have given him, but he has taken it so pleasantly. And every time, even in middle of the night, he would respond to my call, and whatever help was required, he would give it. A very loving person, along with his team, with Dr. Shalini, Dr. Hema, Dr. Manish, and all the other members. And I welcome and also congratulate them for this wonderful module. And I'm speaking last but not least. So don't worry, Dinesh, it's all in the house, and don't worry, don't take it to heart. And it's been a pleasure being with you all. Thank you very much. Thank you.
Thank you. Thank you very much, sir. This inaugural program cannot be completed without the address from our very eminent and mentor, Dr. S.K. Kabra, sir, who is professor at AIMS Delhi. Sir, Dr. Kabra, sir.
Okay, I'll be brief. Good afternoon.
Sir,
all
can
the
you
dignitaries.
open your video, sir? Is it possible?
Yeah. Good afternoon to all dignitaries, national and state level. And I am happy to be part of this module. And I remember when I was in school, I used to read Radhesham Ramayan, in which there was one slok in which it was said that जैसे खांसी सब बीमारी का घर है, उसी तरीके से हंसी लड़ाई का घर है. तो खांसी is cough is part of all the illnesses, at least respiratory diseases. So now we are having this detailed discussion that how to approach a child with cough. It will be useful for clinical pediatrics. Thank you very much.
Thank you, sir. also welcome Dr. Manish Gupta, who is the Secretary-elect, Dr. Arun Garg, who is the Vice President of IAP North Delhi, Dr. Krishan Kumar Jani, the Vice President, IAP Delhi, Dr. Lalit Mani, who will be chairing this session, Dr. Satnam Kaur, Dr. Shitanshu, who is again a very hardworking person and who is the woman behind this module. And I welcome all of you. And now I request Subramaniam sir to introduce this module to the audience. Before Dr. Subramaniam sir introduce this module, let me introduce Dr. Subramaniam sir to this gathering. So, just a minute. I hope my screen is visible.
Yes, it is visible.
Yes, yes, Dr. Dinesh.
Okay. So Dr. Subramaniam sir is a professor in pediatrics at Vaidehi Institute of Medical Science at Bangalore. He's the Honorary Secretary of IAP National Respiratory Chapter. He's the Conference Secretariat of the RSPCon 2017. He is an Executive Member Central IAP 2013. He's a Treasurer, Vice President, Secretary, Respiratory Chapter, Karnataka, Editor-in-Chief, Undergraduate Teaching Module 2011, Editor-in-Chief, Postgraduate Teaching Module in 2018. He had various posts in the IAP. He is a resource person for various modules in the IAP, and he organized many CMEs, workshops, conferences, chaired scientific sessions at the district level and the state level conferences, as a speaker, faculty member at a district, state, and national level conferences. He also been awarded by the IAP for the Best Secretary Award, and he is the Joint Secretary for the Pedicon 2009 at Bangalore. He has field of interest, particularly in the pediatric pulmonology. So over to Dr. Subramaniam sir.
So I think thank you all the seniors and dignitaries over here. It has been wonderful to listen to you, and with all your blessings, we will start the today's session. We need to get charged up. You know, it's afternoon session, and therefore there are two boxes for all the audiences that you are seeing. One is question and answer box and chat box. In question and answer box, you can type questions, and in the chat box, type things like when we ask for. For those of you how to become members of the chapter, everything I will send a link to you. Give me a couple of minutes. But let us get into the module. In the break session time, I will announce everyone how to join the chapter, everything, and you will not go out without nice recipe. Now, are you all ready? Then type yes in the chat box. Are you all ready? Charged up? I want to see the chat box. That means you are active. Audience, can you just type yes, 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 yes? Yes. I want more yes from everyone to come. Hima, I wanted to know, will that, whatever the type, will it come on the chat box here or no? It's coming. There are only two yes. Everybody, 183 participants are there. Please type why. So this exercise is only just a starter for you, that whenever we ask you questions, this is how you are going to interact to us, and then we'll get back to you.
I think we can enable the panel, besides the panelists, the attendees also, na, for the chat box, Dr. Dinesh.
Just a minute.
You want to change any settings, Hima? It's up to you.
Yes,
Right
yes,
now,
Dr. Dinesh is doing, yes.
Yeah, I'm doing so. Just a minute. Give me a minute.
Yeah. So in the meanwhile, I request all the dignitaries to mute so that, the session goes uninterrupted. Please. Yeah. Now, fine. So now shall we start? Okay, I'll start sharing the screen.
Now it's on. It's on.
Yeah.
Attendees can interact.
Now it's fine?
Yes, sir.
Yeah, I can see the chats. Very good. Nice. Nice. Keep typing. You know, your fingers, your brain, everything should be active during the. This is actually a workshop, not a lecture. And we want it to be very, very interactive. So, greetings from all of us from IAP Respiratory Chapter in this module called CAMP. This is cough approach and management in pediatrics. Please go for a pre-test. Dr. Hema and Shitanshu, can you share the link of the pre-test in the chat box? Any one of you?
I think Dr. Dinesh, you can do it.
Because some of them might not have received, but they may be there. Even if it is done also, those of you have not done, just post the pre-test link. No, again, I will start sharing the screen. When we are giving introduction, you can finish. There are 5 or 6 questions and you have to go for the pre-test, which is very important for us. And certificates will be issued based on your pre-test and post-test participation. For those participants who are raising the hands, we will allow you in, not during the session. There are sessions called break sessions. At that time, we will allow you in. One of you, Hima or Shitanshu, can you just...
I have shared it, sir.
No,
There are 4
box,
groups.
in the chat box. Is it okay? WhatsApp is okay? Chat box, can you just copy and paste the link? Those of them
Okay, I'll do that. You continue, sir. I'll do that.
Okay, thank you, sir. So thank you so much. So now this is about pre-test. These are the list of contributors. My colleagues, Dr. Shantanu, Dr. Devji Sharma, Mrityunjay Pau, Rasna Madam, Partha, the young and dynamic EB member from Guwahati, respected chapter, Dr. Shitanshu, who is here with us as a faculty, Dr. Rajkumar. So all these luminaries have spent day and night with us and sitting together and have contributed to the development of module. And of course, later when it was launched in UP, Respicon, Orissa Respicon, and now in Delhi, and last week in Gujarat. So it is getting added by many more resource persons whose name I am not going to take for now. Respiratory chapter always acknowledges the support from all of us whom you are going to see in the screen. So without naming anyone, um, hats off. Thank you. Thank you for the support. Continue your patronage. These sessions will have 4 components. Basically, basics, acute cough, chronic cough, and recurrent cough. And we will see how we can merge the sessions. But remember, on each concept, you will get break sessions. Mind you, when I'm discussing basics, you may get some doubts on acute cough. When I'm discussing acute cough, you may get some doubts on acute presentation of chronic cough. And sometimes chronic cough and recurrent cough causes can be overlapping. Did you understand? So when you ask your doubts, suppose the doubts don't get cleared at the moment, it may be cleared while the module continues. So have some patience, write down your questions or put your questions in the chat box. If they're not addressed, or as faculties, if we see that they're not addressed, we will certainly address them. No question from the participants will be left unaddressed or unanswered. So you need not worry. You can relax and actively participate in all sessions. While basics, I'll be taking you through, later followed by acute, chronic, and recurrent cough. What I meant by basics is some amount of physiology, some amount of pathology that makes the understanding cough as a symptom better and fantastic for all of you. Some of the do's and don'ts of Zoom meeting I have written. It is just that whenever you log in or whenever you ask question, don't identify yourself by Redmi, Galaxy and all that. Please type your name in the device so that we can ask you. Dr. Dinesh, please ask your question. Dr. Hema, please come in. It will be very nice for us to identify you and be interactive. Put the questions only in question and answer box. The pre-test link has been sent and again typed for completion. Certificates will be given based on that. I would request Dr. Dinesh Mittalji be our referee and observe and supervise all the sessions. Please also make a note which participant will drop out so that we will not give them certificates. Rather, I would say the other way around. We'll give certificates to all those people who are there. So the number at the beginning of the workshop, at the end of the workshop should remain same. The learning objectives today are: we need to analyze, assess, categorize, and diagnose cough. Cough is not a disease. Cough is a symptom of a disease, and underlying disease has to be diagnosed. There is nothing like investigation for cough. There's an investigation for a disease causing the cough. So am I just done with a bit of concept? Second is, you at the end of the workshop, you will be able to recognize danger signs of cough and timely referral. So you will be really the best graduate in recognizing dangers. We will take you through an algorithmic approach to the cough. So at the end of the day, sir, what is there in the module for me? So even if you have your own algorithms or textbook algorithms, we'll give you simplified algorithms that you can take through the module. Lastly, we will tell you how to manage in day-to-day practice, including parental counseling, a problematic cough. So this is the overview and learning objectives. And now my session starts, which is essentially concentrating on basics. So my dear friends, so I would request Hima, please remind me. I need to, this is now 2:36 time in my watch. So I would be just taking exactly half an hour from here and finish off the basics.
Sir, excuse me. Before the session starts, let me introduce our chairperson. We have two
Please go
chairpersons.
ahead.
Can you stop?
I'll just stop sharing. You can start. No
Yeah.
problem.
Yeah. Sir. So, chairperson for this session will be Dr. Lalit. Dr. Lalit is a consultant pediatrician at MKW Hospital, New Delhi, and he's the national trainer for the cough module. He's practicing as a general pediatrician. So another chairperson will be Dr. Shekhar. Dr. Shekhar is again a national trainer of IAP at the NRP, FGM, NNF, NR program. He's a national trainer of cough module by IAP Respiratory Chapter. He's a regional trainer of EpiVac, a course on the epidemiology and vaccination. And he is also our executive member at IAP North Delhi this year. So I request Dr. Shekhar and Dr. Lalit to take a seat, and you can introduce Dr. Subramaniam, although he's already been introduced. Dr. Shekhar, you want to say something, or Dr. Lalit, you want to say something? You can.
Let's continue with
please
this.
Unmute. Okay. So I'm stopping the sharing. Dr. Subramaniam, now you can share the screen.
No, what I loved from both chairpersons is that they have put that CV as trainers of cough module, which made me feel proud, and I'm in my tears. So thank you very much. I'm little emotional. Thank you.
All the 6 chairpersons in the module are trained by you, sir.
No. It's
all the 6 chairpersons.
It gives a good feeling. It gives a very good feeling for all of us. Not me. I'm representing all the faculties. I'm not me alone. Okay, fine.
Okay.
So it is so nice for the chapter. Good feeling. Anyway, we will start off with this. Continue the science with your permission, both of you, sir. Okay. Shall we go to basics? Yeah.
Okay. Yes, sir.
No, let's look at some of the issues of basics in cough. Many times we feel that we know, but we will not know enough. So it's time for us to know something in basics. Essentially, cough in a child is a challenge, especially if it is chronic or recurrent. Acute cough is not challenge, but the problem with acute cough is we face it so commonly, yet we manage it differently by different pediatricians. And that makes it, again, even acute cough has been a pseudo challenge, but it should not be a challenge. But definitely, chronic and recurrent cough, which will be later addressed, would be a big challenge. A systematic approach comprising of a detailed history followed by a proper examination is the key to confident diagnosis of rational management of cough in children. And coming to tell you that diagnosis of cough is essentially clinical. And cough is often due to airway diseases and many of the respiratory diseases. The diagnosis is essentially clinical. And if I were to take through uh, the concept of a bit of physiology, my dear friends, so I can tell you that cough is basically voice of the lung. It's also called as tusis. We say pertussis, you understand? So basically the tusis means cough. It's a rapid expulsion of air from the lungs, especially like clearing of the airways in order to clear completely of fluids, mucus, material, whatsoever comes with an explosive outflow. And can you imagine that the speeds can be as high as 100 miles per hour or 160 kilometers per hour? I don't know if you can drive in Delhi Lucknow highway, Jamuna highway, you would realize that that's the speed which this the airflow comes. And do we know that this is one of the most common presenting symptom, most common reasons for referral? And perhaps there is no parent who is not anxious about cough. And I don't know about pediatricians. If your children are also having cough, sometimes you are worried whether I should treat or should I ask some of my colleagues, isn't it? It definitely causes a lot of anxiety. It's it's not a disease. Cough is a protective reflex. And normally also it can be present. It's just physiology. You should have a cough. Don't say I should not have cough. Without cough, you will not survive. And the and a person or a child can cough as much as 11 coughs per day and yet be normal. Suppose some mother says, sir, he coughed 2 times a day. You need not have to write a prescription. Please ascertain, am I dealing with physiology or am I looking at a pathology? So therefore, cough is a symptom of a disease, not a disease by itself. It can arise from various causes, ranging from airways up to extrapulmonary source or a disease. Cough receptors are present everywhere, but majority of them are in the airways. Pulmonary is the main source. Pharynx, larynx, airways, especially major airways, up to terminal bronchioles. So the distribution of cough syrup is pretty simple, my dear friends. See, around larynx, pharynx and all, you have large number of syrups. That's why laryngeal coughs, no, they are very explosive. Tracheal coughs, very barking. Did you understand? But as we move away from the larynx and pharynx, down the airways, the major airways and moderately large airways, the receptors are more. But when you move to smallest of the airways, let's say respiratory bronchioles, the cough receptors are less distributed. And in the alveoli, they are much less. That's why in pneumonias, you don't see much cough. You will see more of breathlessness. But again, I will come from this pharyngolaryngeal area upwards. Let's say we come up in the upper airways, nasopharynx, and let's say up to the nose. When you have cold, you have running nose, but not much cough. The cough in a cold is because of postnasal drip, irritation that you would see. Did you understand my point? So the receptors, the density of receptors on either side of the airways away from the larynx is diminishing, but majority of them are in the airways. You can have an extra pulmonary source. What does that mean? When there is a cough, it also means that you need not worry. It could be even an otitis media, external auditory meatus, esophagus. You eat a chili, you will get a cough. Pericardium, diaphragm, stomach. So what is the message is that please never think that cough is always respiratory. A violent reflux, irritation of lower end of esophagus and the stomach can also cause cough. So it's basically because of the vagal innervation, and maximum amount of receptors are in the airways, and I would say mid airways more than proximal and distal airways. Did I on either side, and upper and lower side. Did I make that concept clear to you? So cuff center is situated in the medulla because a protective reflex it is, and therefore it is in the brainstem. But the afferents come from chemical receptors or mechanical receptors. Please understand, either a chemical stimulus or a mechanical stimulus. What I meant by mechanical stimulus, a touch or a displacement. A touch means you can take foreign body, you can take a mucus, even displacements, all, or even the flow of the air, blast of air that flows. Anything mechanically can stimulate a cough. Chemical receptors like acid, heat, a, a pungent, odor, or whatever, can also, by its property of being irritant or a stimulant, can also stimulate the afferent nerves, basically situated in the vagal nerve or superior laryngeal nerve, and they can go to the center. And there is an efferent from vagus, phrenic, spinal motor. And as I told you, that explosive mechanism of cough happens. But remember, the proximal airways are more sensitive to mechanical stimulation, and distal airways are more sensitive to chemical stimulation. Am I clear? For example, mechanical foreign body lodged, proximal airway cough, chemical stimulation, let's say an environmental irritation, distal airways. Did you understand? So the type of the cough you get, you will know whether it is from proximal airways or distal airways. You are going to demonstrate for you, would also show you the origins of cough. So that's the way you should understand the basics of cough. It's actually a highly orchestrated series of involuntary muscle actions, and with the potential input from cortex. Basically, if you want to cough, all of you can cough now. Actually, it's the cortex that says, okay, go ahead and cough. It gives a green signal. So basically involuntary, as well as there's a voluntary component for it. Vocal cords adduct, leading to transient upper airway occlusion. And when there is occlusion of vocal cord, there is an inbuilt of intrathoracic pressure in the airways, and expiratory muscles contract, generating a very high pressure, as high as 300 millimeters of mercury. And there is a sudden release of laryngeal contraction, and rapid expiratory flow rates are generated. The bronchial smooth muscle constrict, and there's a dynamic compression of the airways that actually, when you narrow the airways in the act of cough, the velocity will get more. It's like squeezing the air. When you squeeze a blast of air, I'll give an example. Let's say you are in the garden with a pipe. When you, and the air you are, if the water you are putting, sprinkling in the garden, you squeeze the pipe. Don't you think the water reaches longer than what it should be? Suppose the pipe is large and wide, the water falls then and there itself. If the pipe is small, then the water gets launched to larger number of plants. So I'm just giving an example. Did you understand? So this bronchial smooth muscle contraction actually builds the pressure and increases the velocity, so that any protection for which the very existence of cough reflexes is there is served. Deep breathing preceding a cough actually optimizes this function. So whenever you want to cough, you take a breath and then cough. Did you understand? So you must understand all these components of cough. And when a patient is there, please observe and understand the physiology. If you understand this physiology, very, very easy for you to diagnose pathology. If you don't understand physiology, just say, sir, cough is present. I'll write a cough syrup. Cough is there, I'll investigate a cough. If you understand the entire concept of physiology of cough, starting from receptors to dynamics of cough, and if you carefully observe the way the child is coughing, you can definitely make out the etiology. I'll tell you, for example, a child violently constrains, tries to bring out, then oh yeah, I think the effort is from somewhere. What's up? That very obvious, isn't it? That means that airways are trying from inside. From both the ways I have made you to understand, by seeing the physiology, you are able to make up or go to the root cause of the cough, which is where the pathology is there. So that takes me to this slide, the origins of cough in respiratory diseases. can be from airway inflammation and production of excessive mucus. It can be from directly from spasm of bronchial smooth muscles, or by the direct stimulation of the cough receptors, either in the airways or in the GI, in the cardia, wherever you want to think, or even in the middle ear or in the external auditory meatus. So specific lower respiratory stimulus, let us come, let's for a minute, let's focus on lower respiratory stimulus. Excessive secretions, cold or dry air, aspirated foreign materials, inflammatory response to noxious infectious agents, inhaled dust particles or gases, allergic processes, so on and so forth, can all cause cough. So origins can be from any one of these. Don't be very dogmatic. Now let me take you through a bit of trying to localize the origin of cough. This next 2 minutes, it is the exercise to localize the origin of the cough. Please concentrate now. The origin of cough can be from upper airway or from the lower airway, correct? The lower airway is not simple. Lower airway has got lower proximal and lower distal. I would say lower large airway and lower small airway. Fine. Now, just for the sake of anatomy, we just have this concept in mind. This will help you a lot. Now, let's see. Upper airway consists of nose, pharynx, larynx, and trachea, correct? Don't worry about the definition of upper airway. But I mean to say proximal, nose, pharynx, larynx, fine. A bit of these are called as proximal or an upper airway. In here, the cough is largely loud, dry barking depending on the area. Nose less, trachea and larynx more barking. We can say upper airway, mid airway, and lower airway. Did you understand? Let's not go to too much of, what should I say, classification of what is the definition of upper airway. Above the glottis is called as upper airway. Here the cough is dry, barking, hoarse. You may have suprasternal retractions, and especially in the mid airway, it is not the cough. It is the obstruction that matters than cough. But cough should be a vehicle for you to go up to mid airways. Am I done with this concept of upper airway? Often it is dry. It is hoarse, brassy. It may be associated with noisy breathing. Okay? Now, in the lower airway, you have lower large airway and lower small airway. And what is the characteristic of cough from the lower large airway? Can you give me the examples? Let's say an asthma or a bronchiectasis. Both, isn't it? It can be intense, periodic, nocturnal, early morning. Some things can happen, isn't it? It's more predominant than tachypnea. Basically, there is a lot of cough than tachypnea. So that means cough is more dominant than breathlessness, especially if it is lower large airway. And you will have rhonchi and expiratory wheeze as prominent in these cases, because if cough is a sign of irritation of the receptors, whereas wheeze is a sign of obstruction. It can be because of inflammation or non-inflammatory, but basically majority of the times inflammation is the cause of obstruction. Lower small airways, I'll give the example of bronchioles. Did you understand? Here, sometimes cough can be absent or minimal or low intensity is from proximal airways. It's from lower small airways. From very small airways. You reduce the intensity, it goes to lower small airways. Can you tell me the origin of cough? Laryngeal. Did you understand? So here, when you go to lower small airways, you may have even absence of cough to very low intensity cough. Here, breathlessness or tachypnea is more dominant than cough. It may be accompanied by wheezing. Best example, I'm giving only example, is bronchiolitis. So if there is significant cough in bronchiolitis, so what it means is in bronchiolitis, you get more wheeze than cough. Okay. But if there is cough more in bronchiolitis, probably the inflammation must have been extended to bronchus proximally. So the virus is not confined to smaller airways only. It has even could be little more. There's no rule that a virus should affect only this part of the airways. Did you understand? Part of inflammation can also extend proximally. That means this bronchiolitis is either severe or it could be bronchiolitis like presentation, but the disease could be asthma. It's happening first time, second time, third time, you will never know. I am not worried about whether you diagnose bronchiolitis, first episode of asthma, or second episode of bronchiolitis, and third episode you want to call it asthma. That's not my intention. My intention is, please understand, have you analyzed the symptom of cough? If you think cough is a dominant symptom, that means you are thinking of airway involvement. If you think wheeze is a dominant, that means you are thinking of airway obstruction. If breathlessness is dominant, that means you are thinking of airway obstruction associated with hypoxia. Have you done with this symptom analysis? So therefore, my dear friends, origins of cough anatomically can be from parenchymal, interstitial, or even pleural diseases. And now I finish with the airways. But here, cough is not a dominant symptom. In parenchymal, interstitial, pleural spaces, what is the dominant symptom? Breathlessness. Breathlessness. In parenchymal, it could be even fever, for example. I'm just giving an example. And other characteristics like type, timing, intensity of cough are different in all these diseases. In a pleural disease, what is the type of cough? He tries to cough, but the pain limits him. So he will hold the chest and talk. If he says, that means he wants to cough, but he can't cough. Or the cough is halted by the pain of pleurisy. Did you understand my point? So it's not just the cough. You must see how he coughs and what he does while coughing. So that can be even pointing to pleural disease. Interstitial disease, the cough is less. He may cough 4 or 5 times a day. The J receptors are there, so they make parenchymal cough. You may get only in the phase of resolution of pneumonia, not during the phase of congestion. So based on the such details, the origins of cough can be ascertained, and it is possible for you. Now, can we have localized the cough? Now, can we localize the disease using the cough? Now, this is the second. Basically, remember, when cough is a dominant symptom, the disease in airways, 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 and airways. So that's very, very important for me. And in the airways, my dear friends, it could be in the lumen, it could be in the mucosa or the wall, or it could be outside. Can you give the example of an outside a mediastin, lymph node obstructing the airways can produce bouts of cough. But what is the other symptom there? You will get wheeze. You will get stridor based on the obstruction, isn't it? Within the lumen, you may have a wet cough. For example, sputum. Did you understand? Say, let's say a wall. A wall means you will get a monophonic or a polyphonic wheeze. So therefore, my dear friends, please understand the combination is the one and analysis is the one which gives you whether the origins of cough is in which part of the airway, starting from the nose to the alveoli. It's not a simple airway. Anywhere the pathology can be there. And it is not difficult, my dear friend. So for me, from tomorrow in your clinic, these physiology concepts are very, very important. Don't write cough present for 16 days, for 2 days, 2.5 days. That's not made. How, why, when, where, and and exactly how he is he coughing. Is it physiology, pathology, part of the disease, which part of the airway? If you ask these questions, I think I'm done with the concept of physiology. When it is pharyngeal, often it is the most common cause of cough. It can be because of multiple factors. It can be just because of opening of mouth due to nose block. When there is nose block, you breathe from the mouth. Your throat gets irritated. And there is exposure of subepithelial collagen and cough receptors. When there is a damage to the epithelium because of the infection, especially viral, the epithelium interepithelial junction becomes weak, and it will allow the exposure of the air to the subepithelial cough receptors. And that's a this kind of irritant cough. Did you understand? And often the irritation can be because of a postnasal drip also. Laryngeal tracheal, it's violent and disturbing cough. My dear friends, you don't ask more questions on cough. Come to a diagnosis. I think the pathology is laryngeal or tracheal. The next question should be, am I dealing with airway obstruction, which is already existing, is imminent like in croup, or no, it should be a red flag sign like in foreign body, or very worrying some like diphtheria. Did you understand my point? Here, the cough is not important. Airway obstruction is important, especially when the cough is violent and disturbing. See, God has given a violent cough for this part of the airways. Why? God gives a good signal. Look here, your child is having violent bouts of cough. That means beware. It could be life threatening. It could be an obstruction in critical path. See, I would say in Delhi, when you are driving, you must realize that, oh, that's a bottleneck road. I should avoid that road. Did you understand? So this mid airway is a very, very important part of the airway. Here to me, saving a child from an airway obstruction is more important than anything else. And that's why God has given violent bouts of cough in this part. See, did you understand the distribution of receptors? And in the alveoli, in the nose, he doesn't want, see, nose is accessible. You can remove something from the nose. So God has given less cough receptors there. So the distribution of cough receptors as a protection by the nature, by the God is beautiful, my dear friends. And it is appropriate for the disease in question and for the way in which our body is prepared. I'm coming back to lastly, lung parenchymal disease. In parenchymal disease, God says the child will have breathlessness more than cough and fever is more than cough. And this is, what does that mean? Here, the signal to the treating physician is, look here, the parenchyma, acini is at stake. So often the cough here is at the later stage of resolution. That's because the there is a congestion, there is inflammation, there is secretion, correct? There is a block of alveoli. Once the resolution happens, the liquid, there is liquefaction of the secretions, and the secretions thrown from the distal acini or alveoli to airways. And airways will throw it further. You need a cuff. Do you want to suppress this cough? No. In fact, God is telling you now, clear the airways. Alveoli is fluid filled. Now his alveoli is clearing. How can alveoli clear? It has to throw the secretions proximally into the airways. From the airways by protective reflex into much more proximally, and it gets swallowed or cleared. Did you understand the mechanism? So therefore, before you treat the cough, think, is it required? Should you clear the airways or treat a cough? So therefore, whenever you prescribe suppressant for cough, this is important. No matter mother tells you, sir, he's coughing now. Oh, we are fed up with pneumonia and fever. Now he's coughing. Give me some cough syrup. Did you understand? So here you should understand the cough and the purpose of the cough. Then your prescriptions becomes rational. And I think I told you about pleural diseases. It is a chest pain with the cough and breathlessness and a dry cough. And often the breathlessness depends on the amount of pleural disease, for example, in effusion or a pleurisy, and that decides the cough. In interstitial disease, it's a mild cough, gradual, progressive, chronic, and child will have other symptoms other than cough. Child is failure to thrive, a pneumonia, interstitial pneumonia, or an interstitial lung disease of a non-infective origin will be very obvious from other features other than cough. There could be clubbing, so on and so forth. The most important components of cough are three. If you have forgotten to understand me from past 10-15 minutes, there are only three components that you should ask. What is the duration of cough? This will give you duration of the disease or duration for which the airways are involved. Second is nature of the cough. I think I'm making you emphasis on understanding the nature of the cough. Lastly, what is the underlying disease? Should I be worried or should I not be worried? Common cold is the underlying disease. Am I worried of common cold? Answer is no. Let's say there is a bronchiectasis. Should I worry? Answer is yes, I should worry, isn't it? So therefore, my dear friends, it is not the cough. The underlying disease is what needs to be researched. So always ask these three questions whenever there is a child with cough. What is the duration of cough? Based on which we have classified the module into acute, recurrent, and chronic. Did you understand? Nature of the cough. So dry or wet and underlying disease causing the cough. So acute cough, my dear friends, fits into a duration of less than generally 4 weeks duration. And this definition is based on natural history of most of the acute upper respiratory tract infection. It is very difficult to get a definition, textbook definition of acute cough properly. Sir, can you tell me, is it 28 days, 28 and a half days, 29 days, 30 days? You mean to say 4 weeks in February, January, October? Did you understand my point? So it's not possible. Please understand my point. If you think that the cough is more than the given natural history of a particular disease, that means it is no more an acute cough. So an acute cough is the one which is associated with acute diseases. And the most common disease is URTI. Am I done with this concept? Second, a chronic cough So here, any cough which lasts more than 4 weeks. Here, the most important point that you need to understand is that you need to avoid the overlapping syndromes. I will tell you a mother who tells me cough on July 1st and July 30th. He says, sir, 4 weeks he's coughing. But if you dissect further, you ask, July 1st he coughed, yes. And July 7th did he cough? Yes, sir. July 10th, sir, it was little less. And again he started coughing from 15th. But for the mother, she will hype and tell you, no, sir, for whole of July, it was a horrible month for me. Then don't make it a chronic cough. Please understand the way in which the symptoms are present, not just the duration. When I'm referring to this 4 weeks, I mean to say you should avoid acute flare-ups of a chronic disease. You must avoid acute overlapping syndromes. A child in a nursery or a play school will get one after another acute respiratory tract infections. And you can't say, sir, this is a cough of 4 weeks, so I will investigate for chronic cough, because in module you told me 4 weeks. 4 weeks is over. So this concept of 4 weeks is like a single pathology or single profile is lasting for more than 4 weeks. Recurrent cough means you will have repeated, not just repeated cough. Here, you should have recurrent episodes of cough, and there should be some interval in between the episodes. It is not recurrent cough. I would say it is recurrent episodes of cough. Did you understand? After an episode, before the next episode, there will be an interval free period, and which will give a hint to the cause of recurrence. And sometimes in practice, I have seen it's difficult to differentiate between a recurrent cough and chronic cough, because see, sir, I don't remember so much, sir. From past 4 months, this is going on. You need real patience to dissect recurrent cough from chronic cough, which Dr. Kabra is going to elicit further. This is the nice study from Cape Town, which has been published, and you can go to this archives 2005, which says a cough which starts will be there for a week. See, when the disease starts here, there is maximum fever, all those things will be there. But as the fever goes off, the cough increases, but the recovery takes long time. See, 2 weeks, 3 weeks, sometimes up to 4 weeks. You can have an acute cough with delayed recovery. And this is called as sometimes post-infectious cough. I'll give an example. Let's say I go to Hema Mittal's house, and she's very anxious with me, and she will make a garam chai for me. And with lot of affection, I will drink with trusting Hema. She must have done a nice chai, and I will drink suddenly hot chai. What happens? I'll burn my mouth and throat, correct? I will get that irritation of the mouth. Wow. Tell me, after I throw the chai or gulp the chai, will the irritation be more during the time in which chai is there in the mouth, or afterwards? It is the post tea, post chai irritation, which is more than during chai irritation. Did you understand the concept? Why I'm bringing this concept is because the parents trouble you post infection than during infection. And this is where a lot of irrational cough prescriptions come. I'm repeating it only for the sake of audience. Please understand. Now the tea is over. Tea has gone. Now I have swallowed the tea. I can't do anything. Now there is a burn. What Hema will do? Subramania sir, no, at least drink water. She will give me cold water. She will give me ice cream. She will give me chocolate. She will give me honey. Correct? So many things she will give me. That will soothe my airways. Correct? That will soothe my mouth because of burns of the chai. But will it cure me? No. There will be, in spite of all the efforts, there will be some kind of residual burn. Are you understanding the concept? So therefore, whenever there is an acute viral respiratory infection, whether it is acute upper respiratory infection, bronchiolitis, pneumonia, bronchitis, anything, following an infection, there is damage to the epithelium, which takes 2 or 3 weeks to heal. At that time, the epithelium is highly vulnerable, and there is some upregulation of cough receptors. Because of infection, the body defense now overreacts. It wants to protect, and therefore the cough will be more. So post-infectious cough is the most common category for which the pediatrician prescribe medicine. They are in frustration because from first pediatrician they come to second pediatrician because nah, sir, cough is not going. Delhi, you know, lot of pollution. So they'll blame so many things. They blame that I have given milk, this, etc. This is the time your reassurance should work. This is the most important point I want to stress for you. I'm not going to discuss this for you because Dr. Kabra is going to discuss this for you. This is a recurrent cough, but you must, how do you identify recurrent cough? You must identify the interval. This is the most important point in the history that you need to exercise. A persistent or non-remittent cough is the one where you cannot find an interval and it goes on every day. If you decide, sir, first half of the week, madam, can you recollect what happened to your child in first week, second week, third week? Please ask the history properly. This is very, very important. A progressive, chronic, non-remitting cough could be a sign of or symptom of an underlying progressive airway disease, and this is where you have to properly evaluate. You all, if you read this interesting article, and this I have told you a skill as to how you should evaluate cough in practice. My dear friends, let me come to a couple of last of my slides. Let's say URTI is the shortest cough, bronchiolitis prolonged, pneumonia, pertussis much more prolonged, tuberculosis much more prolonged. Just this is a bird's eye view of how you can get the diseases commonly in practice by timeline. Regarding the onset of the cough, so whenever the cough is of 20 days, 15 days, you just ask the onset. Let's say it's started with onset over several hours and there was no fever, it is allergic. Onset, acute onset but progressed, can be an infection associated with fever. Did you understand? An explosive onset, choking, foreign body. No, sir, sudden onset, acute flare-up of asthma. Did you understand? Is it difficult? By just knowing the type of onset, you can know the diagnosis. By the type in which it progresses, you can make a diagnosis. Episodic, but only in the night, asthma, post-nasal drip. Even here, early morning is asthma, just 15 minutes after sleeping is postnasal drip. Cough that immediately happens on lying down can be postnasal drip. Can it be reflux also? Yes, gastric reflux, early hours of the morning. Dry cough is asthma, wet cough is suppression. Gradually worsening can be pertussis. For example, second week is worse than first week, third week is worse than second week, can be pertussis. Did you understand? Even the way in which it progresses. And after feeds can be reflux, worse in the evening can be pollution, exercise triggered by dust, etc., can be asthma. Loud, bizarre, but absent during sleep can be psychogenic. Examples of cough at different ages. You know, in infants, most often it's viral infections, reflux, congenital anomalies. And in early childhood, it can be foreign body asthma, retained foreign bodies. Based on this acute, recurrent, or persistent. Don't worry about taking down any notes. All the participants, you WhatsApp to my number, I'll send a PDF slides to all of you. We have no issues regarding copyrights. You can freely read anytime, but don't copy and present it elsewhere. You take the permission from the chapter. You can, I'll share all this knowledge. You need not worry at all. We'll send you all the slides by PDF for all of you. So please try to interact and understand in a workshop. All these are available in literature, journals, books. You need not buy mug, by heart. We will send you all the material. In older children, asthma, rhinosinusitis, bronchiectasis can all be the cause of acute, recurrent, and persistent. Most important question I would always ask, is the cough dry or wet? A dry cough means often it is because of an irritation, upper airway or lower airway bronchospasm or inflammation. Did you understand? A wet cough means there is production of secretions, isn't it? It's often recognized by rattling in the chest or by expectoration of the sputum. Sir, all mothers tell me there is kapham inside, take it out. Even in dry cough, they say, sir, something is stuck. Can you give some medicine to bring it out? Often it is dry cough. Did you understand? But sir, then how should I ask history of wet cough? No mother says, I'm bringing out a sputum out, correct? How can a child says and show you the sputum like an adult? It's very difficult. Of course, when it shows a wet sputum, it's really late for us. We should be able to recognize a wet cough much before it brings out a copious sputum. That means we are very late. Already bronchiectasis or some other disease has happened. Did you understand? How can I recognize? It's very easy, my dear friends. I'll give a small hint, but my apologies because I'm going out of evidence-based medicine. But this is what I do in practice. Maybe you can call it out of the module or out of the box advice from me. You can take it. Let's say you make the child lie down. Okay. Now this child has a cough. You put your hands on the chest. Okay. If you can palpate gora gora, gora 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 gora, you understand? The secretions will be moving to and fro. I don't know, you many of you can do this. Not, I'm not referring to conducted upper airway. No. You can really feel the lower airway movement. Gor, 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 gor secretions. That's a wet cough. Mother may or may not tell you. And I want you to comment on the chat box. Is this your experience also? Just I want to take a kind of opinion from you. Do you all agree? Yeah. When you put your hands on the chest, you will all feel that moving. Something below your palm. Secretions moving. Can you feel that? Yes, that's a wet cough. And you can pick it very easily. And most of the children cannot expectorate a wet cough. And it's very easy for you to recognize a wet cough and a dry cough. I tell you, the approach will be totally different. My dear friends, wet cough you cannot ignore. A dry cough is where you have to find out from where the dry cough of irritation is coming. Wetness of cough means it is not the ability to expectorate the sputum. This is what is seen in adults, not in children. It can also mean wet sounds that are produced while the child is coughing. This is exactly what was the explanation I was giving to you, my dear friends. So therefore, a loud, dry, barking, brassy cough, such as a tracheal involvement. Hoarseness means laryngeal involvement. In dry cough, also you have two types. Dry hacking cough is pharyngitis. Honking cough is habit cough. We'll show you all types of cough. Throat clearing cough is because of postnasal drip. What do you mean by throat clearing cough? If I ask you, any one of you to sing a song, okay, I will sing a song. You will do, no? That is called throat clearing. It's because of postnasal drip. Dry irritating is post-viral. Barking is laryngitis. Brassy is tracheitis. Paroxysmal, that means it comes in bouts, is persistent asthma. I'll show you. Paroxysmal means it comes in bouts. If it continues, it is called paroxysmal. Did you understand? Nocturnal is asthma. Wet and rattling is because of suppurative lung disease. Now I have cleared my throat. I can't show you wet cough. Did you understand? So it's very difficult. So wet is because of suppurative lung disease. You can't ignore the past. Whenever a child comes in the past, it could be acute presentation of a chronic disease. You must always ask, was this child preterm? Was there hospitalization? Was it intubated? Yes, so therefore airways were damaged. Was it ventilated? Was there any surgery done? Let's say a tracheoesophageal fistula is repaired and the child continues to cough. You should see in that background. Was there a vaccination done, not done? Whether the environment, dust, pets, pollen, location of the house, environment within the house, overcrowding, whether that's where the child sleeps, whether there is AC, non-AC. So Delhi, non-Delhi, Noida, North Delhi, South Delhi. I don't know which part of Delhi is more polluted than the other parts. So I don't know. So it's you know better than me, because I am from Bangalore. I visit Delhi often, but when I visit, I don't get a cough. So thank you so much. So role of investigations are very, very important. And I can give you a broad view. In chronic and recurrent, investigations are important, but don't write panel of investigation. Sir, if a chronic cough comes, I'll do an X-ray, I'll do one Mantu, I'll do one sputum, I'll do this, PFT, 5 hai na. So don't go by packages. Your history and examination should direct you to investigation. So investigate the disease, not the chronic cough. So I suspect TB. I suspect cystic fibrosis. I suspect bronchiectasis. So there is investigations for that. Did you understand? You must do a single investigation which clinch your diagnosis. If you do 3 or 4 investigations, that means you have not taken proper history. Only one investigation. I will do bronchoscopy, sir, and I'll get a foreign body. I will do CT chest, sir, I'll get a bronchiectasis. Did you understand? Then cause of bronchiectasis, again, you can go further. That's different. In acute, the challenge is that you must take appropriate history to separate hyperacute or just acute. Rarely they require investigation. How many of you see, if you see thousands of cough, 1 or 2 you may do investigation. Do you understand? Most of them resolve, and your skill is as a consultant, how do you counsel? How will you smartly diagnose? How will you not allow an acute presentation of a chronic cough? So this is where your smartness lies. Investigations, my dear friends, so therefore, in routine day-to-day practice, if you do X-ray, just will be normal, just for a cough, not for a disease, in majority of the cases. But in a chronic or recurrent cough, first investigation I would request you is to do a chest X-ray. If you look at an X-ray, when you suspect foreign body, chronic or recurrent cough, it's often normal in all these causes. Persistent shadows you can see in these causes, focal shadows you can see in these causes, multifocal shadows you can see in these causes. Anyway, there will be again sessions on this. So I'm giving you an overview. Interstitial patterns also you can make recognized by chest X-ray. So other suggested investigations do not go by cough, but by these diseases. So for TB, you do this. For aspiration syndromes, you may do this. For congenital heart disease, you may do this. I'm not going to go to the list of these, but investigations are directed by the disease hint that you get from the cough. Okay, fine. When to worry? Sudden onset. It could be foreign body, choking, or not necessarily just foreign body, even acute airway obstructions, which are life-threatening. Neonatal onset. See, newborn should not cough so much, isn't it? So something to worry. Relentless progression, progressive cough, wet cough. And I told you how to recognize wet cough. Other symptoms like hemoptysis, failure to thrive, clubbing, developmental abnormalities, you must worry. Breathing difficulties, cyanosis, weakness, or if there are comorbid conditions, you must worry. So I'll come to the end of my presentation. Do you all agree? If you agree, type yes. Cough is a protective reflex God has given. Don't modify it. Allow it to naturally heal. Don't treat this protective reflex. Don't try to meddle with the nature. Leave it alone. Everything will be fantastic. It's basically a protective reflex. All of you have typed yes? Yes. Do you agree that it is a commonest complaint in pediatric OPD? Masterly inactivity, wonderful eyes, a beautiful presence of mind, and lots of common sense, but not pediatrics is required. Do you agree somebody is coughing? A child. And all of you have been parents. Something small needle prick happens to your child. Oh, what happened, Papa? Nothing would have happened. But you will see, oof, 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 oof. You will do 100 times. Did you understand? When a child coughs, parents are worried. Don't treat the child for parental worry. You treat the parent. You give cough syrup to the parent. Let them sleep off. Why do you make the child sleep off just because the parents are worried? And parents continue to be worried, isn't it? It's not possible. Don't chase the parental anxiety. Cough is a symptom of an underlying disease, not a disease by itself. And when cough is a main symptom, pathology is in airways, and only airways. Associated symptoms sometimes will help us to etiology of cough. Breathlessness more than cough, lower small airways. Acute onset of breathlessness, critical part of the airways, which I told. Clinical evaluation is the mainstay in diagnosis of cough. My dear friends, in most of the times, investigations are not required. The way you ask, the way you demonstrate, the way you visualize, the way you ask a mother, the way she shows the cough. Sometimes when you see a cough in the clinic, is what will give you the diagnosis. And beware of red flag signs. This is the time you don't waste time. Even in doing an X-ray, if you have choking, directly send them to a place where there is bronchoscopy. Don't wait. So we'll break for an interactive session 1. This is where we would be going for cough mimicry. I'll stop sharing for a while. So anybody who wants to mimic a cough, I would allow you. Shitanshu, Hema, any of you have mimicry by Dr. H. Parmesh? If at all you have in your laptop, you can share. If you don't have, I will have to mimic the cough. And I would ask somebody to raise the hands. Can you mimic the cough for me? Otherwise I will mimic. If there is time or no time, I don't know how much I've overshooted my time, but I couldn't see the time. So some inputs from my couple of colleagues from me, Hema and Shitanshu, unmute, and now you join us. Now we'll go for cough mimicry. This is only for a short period of time. What we shall do? Do you have?
I don't have the video module, sir. I think you must be having it.
Shitanshu, do you have in your laptop? If not, I will just do the mimicry.
It will not be because no, sir.
Not there. Fine, fair enough. I will try to mimic the cough. Anybody from the just let's have some fun. Dr. Lalit, you want to volunteer? No, you look young for me.
Huh? So if you have, for the benefit of audience, we can put into the WhatsApp group also.
No, I'll share it. I'll share it. No, we will 100% share it. Nothing will be hidden. Everything is open. This cough module should go up to general practitioners, not pediatricians. Our aim is to reach out to the 2 billion Indians who are the doctors. Everyone will have. Lalit,
Yes, sir.
just I want you to have, let's have some fun here. Come on. Now you mimic, no, don't worry, let it go wrong. You just mimic, you recollect your day when you had common cold and just demonstrate for the audience how at that time you would have cough.
Common cold, sir.
And now during cold and pharyngitis. No, you are bringing it, you are anxious, you are bringing it much more deeper from the airways. Dinesh sir, no, let's have fun. Don't worry. Yeah? I'm having some fun. Dinesh sir. Very good, isn't it? Correct, no? Lalit?
Yes,
No,
sir.
he brought out a nice cough. Shalini, you want to try?
Yes, sir.
Try. Doesn't matter. URTI. No, you are going little lower down. Correct? Yeah. Doctor, anybody else? Okay, I'll just show you. Is an upper airway cough. Did you understand? This is how they cough. So very important. If the child coughs in the clinic, please remember this is a pointer to upper airway. If you go down, tracheal. Anyone wants to volunteer? Shitanshu, Hema, volunteer? No. Okay, good. Sir, you are getting from inside. Very good. No, but you should bring that barking cough. You must bring that voice as though you are blowing into a hollow vessel. Did you understand? Trumpet blowing type of cough. That's what is because of tracheal. I shown you, very difficult. If you don't treat them, they'll thrash you also. They may hit you also. Sir, what is this? आप बोल रहे कुछ नहीं है, इतना है. You understand my point? That's honking. That is because of tracheal. You go to lower down, bronchial and proximal. Now it is bouts. And why bouts? Because you have to push from smaller to much more larger to larger to proximal. There's attempts, sequence of coughs you will get as and when you get medium and small airways. Did you understand? So they are in bouts. So if you get a bouts of cough, pertussis, asthma and things like that are likely. The airway doesn't know. It thinks that a dog, when you go, a stranger comes, it just barks. It doesn't know whether he is your friend or enemy. Its job is to bark. So likewise, you get a cough. Whether it is asthma or TB, what does it matter for the airways? It just produces a cough. When you go to lower small airways, when there is an associated wheeze, this is how you get the cough. Did you get a wheeze component associated with the cough? So that's where you get a smaller airway getting involved. Did you understand? And when you get a parenchymal disease, the cough goes to lower intensity. Now you have to reduce the intensity of cough. This is a kind of statico kind of cough or a recovery from pneumonia. It is settled. You try to push from smaller airways to, acini alveoli to airways. I'm not so good in mimicking these coughs, but I tried my best, because unless I have a pathology, I can't mimic. I was trying to get that from that part of the airway. It's very difficult. So I did my best, but still there could be excellent audience. At the end of the workshop, we'll allow each one of you to mimic the type of the cough. Okay, the best mimicry would get some award from Delhi IAP, not from respiratory chapter. Hema, okay? Yeah, fine. Now we will go to the next session after this mimicry is over, is on acute cough. Now I will invite Dr. Hema and over to chairpersons for a couple of comments. Dr. Lalit and Dr. Shekhar, you couldn't comment anything. I think you can now
an excellent session
and comment, and then with couple of quick comments from you and end up of session, the way that organizers have decided to take the flow, you can go ahead, and I will hand it over to the next speaker.
Dr. Subbu, it is always a pleasure to listen to you, and it looks like I should listen to you keep on and on and on and on. I did the cough module in September, late September, and then also I thought I learned something new. And today when I'm a panelist, I'm still learning. So it is always a pleasure to listen to you. Hats off, sir.
Thank you very much. Lalit sir, with 1 or 2 remarks from you, there will be some
Excellent
small
session, sir.
break for the audience, no?
Just clearing all the
One thing
doubts
you have
about
to,
cough and basics of cough.
yeah. So
So,
even
so there
I
is
request,
clear scenario of breakout session also.
yeah, we have
Should
got
we take
breakout
right now
sessions.
or?
This is a breakout session.
Okay.
So everywhere you will get breakout session. So you audience can relax. This is spread over 2 or 3 hours, but we will have sufficient interactions for every one of you. If you have any questions that have not been answered, please let me take up those questions. But we will go to, I'm just seeing, fine. I think, um, so even in a parenchymal disease, you need not do a chest X-ray. Suppose you have tachypnea, fever, it is pneumonia. Only when it doesn't respond, you can do a chest X-ray. So therefore, parenchymal does not mean always chest X-ray is required. And many times in X-ray also, you will see only 2/3 of the lung. More than 1/3 or 1/2 of the lung is hidden in an X-ray, behind the ribs, in the mediastinum, behind the clavicle. Did you understand? There is lungs everywhere, but all those are opacified behind the liver. There is lungs, but you don't see on an X-ray. Did you understand my point? So only part of the lung is seen, or part of the parenchyma is seen. So therefore, a normal X-ray does not mean normal lungs or normal airway. So therefore, be careful. Airway is not seen except proximal airway. So airway is seen only when there is air bronchogram because of surrounding fluid in pneumonia. So therefore, in X-ray would be deceptive, so be very careful, and X-ray will not rule out foreign body. All these points will come in the next session. I'm not going to take her session. I will hand it over to the next chairperson and Dr. Hema Mittal.
Yeah.
Somebody is asking me to demonstrate statico cough. Okay, I'll try again. You should come in sequence. You understand? This is how a statico cough would come. It's often because of chlamydia and others. Chitanshu will further explain to you again when the scenario comes to you.
Okay. Thank you,
If there is any
Subramaniam,
demand, please ask. This is a workshop, so it's not a lecture. Anybody wants anything, you can type in the chat box. We'll just do it for you. Otherwise, if you have understood, we'll go ahead. Tick cough. Tick cough will demonstrate. Okay, next, what else you want? Somatic cough. Okay. Tick cough is you will cough when you are conscious or when you are seen. When you are not observing me, I don't cough. So cough is same. It's like it's a light cough. Light cough means ज़्यादा tension वाला cough नहीं है. You know, suppose you want to draw your attention to someone, what will you do? You know, hi, you will tell, or else you tell. That means you are not asking them. Suppose one of the chairperson says that he wants to be attended, you will say, then that in the Zoom that will come out. No, this is in a lighter way. No? This is just a joke. So you will prop up or you will seek the attention. This is exactly what happens. So cough is a voice, and the cause of tick or the disease underlying that is important. It's not a cough. I will just share with you because there is a question I'm answering, but the question will be answered again by the subsequent sessions. Just because there's a question, I will finish off this concept. What is important here is the disease. The disease underlying the cough. I had a child with sexual abuse, 4-year-old child, which was coughing for no reason. 4 days it coughed, and next 4 days it had pain abdomen. That means there will be switching of symptoms. Symptoms analysis will have disarray of symptoms, not matching with the findings. Did you understand my point? Nighttime, absent, attention, all these things will be there. So therefore, my dear friends, it's very easy for you to diagnose psychogenic or ticks and other types of cough variants. Fine? Okay, over to the next session.
Thank you, Subramaniam sir, for a very interesting lecture. And we already attended this in September, but definitely it was very interesting, and I feel like attending again and again. And sir, I started practicing in my practice also. Now, for the next session, to make this session more interesting, we are taking case scenarios by Dr. Shitanshu Srivastava, and I would like to just welcome Dr. Shitanshu. She was my junior at the same, we were at the same medical college, and pleasure to have you here. And now I would like to invite Dr. Shekhar, and we will introduce Dr. Shitanshu.
Hello, everybody. and welcome Dr. Shitanshu Srivastava. She is from my hometown Lucknow, the city of Adab and Tehzeeb. So Adab and Namaskar from all of us from Delhi. And she is an associate professor of pediatrics at Dr. Ram Manohar Lohia Institute of Medical Sciences, a master trainer of IYCF, ATM, BNCRP, asthma and pediatric allergy. And she is ex-HOD of Department of Pediatrics from 2015 and 18 at ERA Institute of Medical Sciences, Lucknow. She has been executive board member of UPI from 2010 to 2021. She is organizing secretary of UP Respicon 2018, UP Pedicon 2019. And she has many publications, been a thesis guide, reviewer of national and international journals. Welcome you, madam, to the COF module in North Delhi IAP.
Dr. Siddhanshu, now you can share your screen if you want.
Sir, I just wanted to add here, like, because we had a break session here. So we have included a break session after the episode, in between the episode of acute cough. So Dr. Hema Mittal Gupta will be taking the session of acute cough, and we'll be having a prescription writing session, which will be a break session now. So
Okay.
I think Dr. Hema Gupta will continue with the acute cough now. Yeah.
Okay, fine. So now I invite Dr. Pankaj Garg, who is our ex-president of IAP North Delhi. And I request Dr. Pankaj to introduce the next session and the chairpersons for the next session.
Good afternoon, friends. This has been a very interesting session going on. Such a simple common symptom, and how can you really analyze it to its full length, which gives you better insight and as to how to treat this. Though I'm a neonatologist and newborns don't cough, but cough is such a common symptom in pediatric practice that all of us have to be very, very pertinent in dealing with it on day-to-day basis. Now, coming to the second part of it, we are coming to the acute cough and management part. Now, acute cough and management part will be taken by Dr. Hema Gupta. Dr. Hema Gupta is a dear friend. She is the better half of Dr. Dinesh Mittal, and she is working as head of unit of pulmonology at RML Hospital. So I will be requesting Dr. Hema Mittal to make the presentation, and as Dr. Shitanshu just mentioned that she will be taking the break session after acute cough. So we have to invite.
I request you, sir, to introduce chairpersons.
Yeah. So we have to introduce chairpersons, Dr. Satnam Kaur. Dr. Satnam Kaur is MD Pediatrics, Senior Specialist Department of Pediatrics, Safdarjung Hospital, New Delhi. She is trained in pediatric pulmonology from AIMS, New Delhi, and she has done clinical fellowship program in bronchoscopy, division of pulmonology, Chosun University Hospital, South Korea. So I welcome Dr. Satnam Kaur. And Dr. Manish Gupta. Dr. Manish Gupta has been a very good friend of mine as one of the very important members of IAP North Delhi, who has really worked hard to reset the image of IAP North Delhi, which all of us enjoy today. He is currently working as senior consultant pediatrician and neonatologist at Jaipur Gordon Hospital. He is a DNB teacher. Right now, he is working in capacity of Secretary-elect IAP Delhi. He has been past president of IAP North Delhi. He is IAP trainer for National Resuscitation Program, asthma training module, allergic rhinitis and comorbidities training, and clearing pediatric airway. He has special interest in pulmonology and vaccinology. That is why he's here on this panel of chairperson for this module. Thank you so much.
Now I request chairperson to introduce the speaker. Dr. Satnam or Dr. Manish, you can introduce the speaker.
So
So now we'll have the session on acute cough by Dr. Hema Gupta. As has already been mentioned, she is running the pediatric pulmonology services at Dr. RML Hospital, New Delhi. Also, she has got European diploma in pediatric respiratory medicine by ERS, and her special interest includes pediatric pulmonology, sleep medicine, and pediatric nutrition. She has many publications in the national and international journals. She has written many book chapters, and she's a national trainer for various IAP modules. So, without wasting any more time, I invite Dr. Hema to start the session on the acute cough. Dr. Hema.
Thank you, Dr. Satnam, for your kind words. I'm just sharing my screen. Is my screen visible?
Screen is visible, but we are not able to see the PowerPoint.
Okay.
Hello.
Any help you want? You want me to share the screen?
Dr. Hema,
Hema?
Sir, I'm sharing the screen. Sir, I'm sharing the screen.
Okay, done.
Kindly, yeah. Is the screen visible?
Yes, it is visible.
Yeah, it's visible. Shetansh, you can go ahead.
Yeah.
If she cannot log in due to some net reasons, you can only.
Thank you, Dr. Shitanshu, for sharing.
Yeah. Okay.
So we now go forward to acute cough, which is the main thing in this crux in the whole module. So we have the learning objectives is we have to enable ourselves to quickly analyze what is acute cough. We have to formulate the diagnosis, and we have to know the rational management of the cough. Next slide, please. So just an overview, what is the etiology of acute cough? How do we approach to cough? What is the understanding of cough character? That we have already discussed the onset, duration, and the progression of cough. We have to look at the associated symptoms and their importance. We have to see for the management of cough, identify the red flag signs in acute cough, where we need to alert ourselves, and just then summarizing. So this is what I will be discussing in next 30 minutes. Next. So what we learned in the previous session, we learned that cough is a defensive mechanism. It is actually very helpful to us it is actually protecting us and alarming us. Then what is acute cough? Acute cough is any new onset of cough, which is for less than 4 weeks duration. Besides that, we would label a patient as chronic cough, and we will see in the further section with Dr. Kabra. So now looking at the anatomical origin of cough. So cough can basically originate from the upper airway or the lower airway. The lower airway can be the larger airway or the smaller airway. So looking at the characteristic of cough which is there in the upper airways, the cough would be loud, dry, and barking. It may be either brassy or a hoarse cough. Then there can be additional things like stridor, which will be present in upper airway diseases like laryngeal or tracheal diseases. There may be retractions, which are mainly suprasternal retraction. A perfect example of this would be a patient of croup. So this would be the characteristic cough which is present in the upper airway involvement. If I talk about your larynx and the trachea and the epiglottis. Now coming to the lower airways. So the lower airways can be the larger airways, including the main bronchi. So the cough in this would be intense, it would be periodic, and often nocturnal cough would be there. Cough is a more prominent symptom than tachypnea if the patient has lower large airways involvement. Bronchi and expiratory wheeze are again very prominent in this category. So the characteristic disorders in this category would be bronchitis and asthma as we commonly come across. Then how about the cough in the lower small airways? In smaller airways, as we already discussed, the cough would be a minimal finding. It is the absence of cough or a cough of low intensities. Characteristically, if we see our patients of pneumonia or bronchiolitis, are the dominant symptom. So what is the predominant symptom in these? The predominant symptom in these is tachypnea, minimal cough, and wheeze. So we have seen that how the cough varies and the other thing varies as we go from the upper airway to the lower small airways. Next slide, please. So now let's see what is the etiology of acute cough. Next. So the etiology of acute cough can be either it can be respiratory causes or it can be non-respiratory causes. The respiratory causes would include the infective causes and the non-infective, that is by largely allergic in cases of most common cases. So the infective causes can again be divided into acute upper respiratory tract infections and acute lower respiratory tract infections. Besides this, we can have allergic involvement, which is most commonly seen in disorders like asthma. Then we can have non-respiratory causes of origins of cough, which can be because of cardiac conditions like cardiac failures can be there. Then there can be aspiration syndromes, like we can have gastroesophageal reflux disease, which may cause recurrent aspirations leading to cough, which might be prominent. The third cause can be, it may be a habit cough, which the child has formed, and maybe because of the habit or the attraction towards the parents, he has cough which is there. Important cause which cannot be left in pediatrics in hyperacute cough is foreign body. We all have seen with our experiences that foreign body is an important cause of acute cough, a sudden cough which is there. Next slide, please. Okay, so now let us see what are the associated symptoms in cough. We all know that cough may be associated with fever, cold, and breathlessness. So over here, we'll just try to compare the infective cause like a viral cause as we discussed and a non-infective cause asthma, which with all these symptoms. So we see that cough in a viral cause is not that as important, though it is present as compared to asthma, which is a lower, larger airway disease. Again, breathlessness is not much seen in a viral illness as compared to asthma. So cough and breathlessness are more common symptoms of lower, larger disease like asthma, which is a non-infective disorder, rather than the infective disease. Coming to fever, fever is present in viral disease and it may or may not be present in asthma. We all know that asthma may be triggered by viral inducers at infection stages. Coming to cold, again, it is more prominent feature in viral infections rather than asthma. So to summarize, in viral infections, the main symptom is cold and fever, and in asthma, the main symptom would be cough and breathlessness. Next slide. Okay. Now coming to viral infections. So viral infections we all commonly encounter in our practice, that the mother generally brings a child with cough and cold with some amount of fever which is there. Cough and cold is very significant. The mother generally says that the child keeps on coughing and the child has rhinorrhea. The fever is there, which may last for 3 to 5 days, and then it may wane off. And the child is active when the child doesn't have any fever. So this is how a child with viral infection presents. Next. Now what happens to the progression of the disease if we see? So the cough gradually increases over the next 3 to 7 days. By the child mother comes to us, the fever is okay. Most of the time she says, कि जुकाम खांसी स्टार्ट हुआ था, बीच में बुखार आया था, but बुखार ठीक हो गया, but cough अभी भी रह रहा है. That is why what we most commonly see. So it lasts for about 2 weeks. Sometimes it may last for 3 to 4 weeks as a post-viral cough. And on examination, we have a lot of findings. We may have the child having rhinorrhea, the chest may have certain findings. So this is how the cause for a viral infection. Next slide. So now let us understand what this chart shows. It typically shows that with all these things, with presence of fever, cough, with the presence of nasal discharge, which is there. So we see that in the lower half, we see that the fever and the cold. In most of the children, they respond for within the first 3 to 5 days. If we see that fever and sore throat is the main presenting symptoms, they normally resolve in the first 3 to 5 days, and they may maximum persist up to 7 to 9 days. However, if we see the upper part of the graph, we see that the cough and the nasal discharge, which is a prominent symptom, does not resolve and may persist up to 2 weeks in around 30 to 40% of the children. So we see that cough and nasal discharge persist, but fever and sore throat may improve after the first week. So this is important for us to remember, because most of the patients which come to us clinically have fever which has resolved, but now the mother is more anxious and more worried for the cough and the nasal discharge which is persisting. Next slide, please. So how do the bacterial infections present? We have normally covered in the previous section about the viral infections. So now see how do bacterial infections present. So bacterial infections start with significant fever at onset, and they may increase gradually. The child may be toxic. In cases of high fever, the cough normally starts after 3 to 4 days. We saw in the viral infection that cough and cold starts prior, and we see in bacterial infections, the cough comes after the fever, and the localizing signs in either chest as in pneumonia, or it may be pharynx in cases of streptococcal throat infections might be there. The child is not active when the child doesn't have fever. So we see that there's considerable toxicity in cases of bacterial infections. So what is a general dictum? More severe the cough, the lesser the chances of bacterial infections. As we already learned that the cough is more prominent and more intense in cases of upper airway disorders rather than the lower airway disorders. So we have to remember this dictum. Whenever the cough is severe, there is less chances that it is a bacterial infection. Next. So when do we prescribe antibiotics? So antibiotics are prescribed only in 3 conditions. Either you have a streptococcal sore throat, which is there, you have pneumonia, which is obviously there, and the third condition would be epiglottitis. So the general dictum would say that more severe the cough is, the lesser is the need of antibiotics, except in the cases of pneumonia where the cough may be less, but then you require antibiotics. Next. So remember that in diseases where antibiotics are indicated, cough is not very significant. So this actually summarizes most of the thing, that whenever a patient with cough has a persistent problem or the main problem is coming to us, antibiotics is not the right answer to us. So I think when we are prescribing antibiotics, we should again rethink when a patient of cough is coming to us. Next slide. So now, when do we investigate a child of acute cough? Most of the time, in 80% of the practice, we see that the child with acute cough is coming. And then when the mother comes to us, then we are in a dilemma that what investigation should be right and whether it is right to order these investigations. So now let's see that what it will be wiser, when to investigate the child and what investigation should we order. So first coming to the blood counts. So the blood, can we go back to the slide? So first coming to the blood counts, coming to the CBC, blood counts are usually not indicated if the history is suggestive of a viral or a hyperreactive airway disease. They can be ordered if the history is suggestive of any bacterial infection. So we may get a clue about leukocytosis. So we should refrain ourselves from ordering a CBC, as all of us mostly do. Then what is an indication for throat swab? Throat swab should be reserved for patients when we are suspecting bacterial upper respiratory tract infections rather than ordering it in all conditions. Indications for nasal swab would be, as obviously in the current season of COVID and in flu cases, then other cases would be SARS and MERS, where we can get a PCR done, and a respiratory biofire, which may be indicated in certain conditions. We should not be ordering in all patients, which is very expensive investigation, somewhere costs around 13 to 20,000, which should be reserved for particular specific conditions only. Then when should we get a chest X-ray done? So chest X-ray should not be actually ordered in all cases of cough and cold. We should reserve them for the patients if they have additional danger signs or have additional findings like hypoxemia is present, the child has crepitations, there is significant chest pain, there is decreased airflow, and history suggestive of foreign body where we can find specific findings of hyperinflation or a collapse, etc. So the dictum again over here goes, when should we investigate a child of cough? More the cough, the lesser is it in need for doing a chest X-ray. Exception would be always over here, foreign body, when a child presents with acute severe cough. Next slide, please. So no investigations up till now, no role of antibiotics up till now. So how do we go for management of acute cough? So up till now, we have learned what is acute cough, what is a characteristic of bacterial versus viral versus allergic cough, and what is the role of investigations. Now let us come to what is a management of acute cough. So the management of acute cough can be pharmacological as well as the non-pharmacological methods. Now there can be benefits versus harm for both of this. So I think the next slide, we break out for a session, and I request Dr. Shalini to please announce for the next session.
Next session will be taken by Dr. Shitanshu, I think.
Yeah, Dr. Shitanshu, we have a break session and then I will continue again.
Yeah. Thank you so much, Dinesh sir, Dr. Hema. So I would like to, because this is a type of workshop itself, so we are making for an interactive session now, and that would be a prescription writing session. So I would request all the learned participants just to open your chat box. I would invite Subramaniam sir to be into this for the interactive discussion. So we'll be having a discussion on this. So this is a case scenario, and this is basically a prescription writing workshop in which we encounter day in, day out. We are doing this in our OPDs, and this is not something new for us. But there are some very important messages in this. I think Subramanian sir will try to elaborate on that also. So, we begin with the case. There is a 3-year-old child who comes to us.
Just a minute, ma'am. We have a facility if you want to put some delegates on talks, and if you want that they should speak something, we can put him on talks.
We'll call.
We can allow them.
We'll call at least few of them. We will take that. No problem.
Okay.
No. Don't type now. Don't type now. Don't type now. We'll tell you when to type. Chitansh, you continue the case. Carefully listen to the case.
Yeah. There is a 3-year-old child, Vibhu, who comes to us with URTI, upper respiratory tract infection, seen by another pediatrician. So accompanied by a troublesome mother and also a grandmother. Basically, the trouble is with the troublesome mother is a very common scenario, because the grandmother is also there, and she's saying the child is very ill and there is something needs to be done. So just an episode of URTI 7 days back. So now this is a scenario, and what would be your prescription? I think, sir, we'll allow them.
No. Wait.
Okay.
No, they'll just see. I want all the participants now do one thing. No, don't type for a while, please.
Okay.
Put your hands on the chest and tell me that you will type truth and nothing but truth. This is how they do in the court of justice. I know what you will type. And you will type something else in the clinic. So now all of you, have you put your hands on the chest? You don't worry about your identity. We are not going to criticize anyone. We want only truth, nothing but truth. Okay, that's point number 1. Point number 2, you assume that you are just beginning your practice. You want to catch patients, and the neighboring pediatrician is very busy. She sees hundreds of patients. You are seeing only 1 or 2 now. And the grandmother is not happy, mother is not happy with the next pediatrician. She wants to try a new pediatrician. And you are there sitting on the hot seat. You have pressure from the rep, pharma, mother, grandmother, and from yourself for establishing your practice. All are there now. Okay, is the scenario clear? And satyam, only truth, nothing but truth. Okay, now you type in the chat box. Continue. Nasoclear drops, Timinic syrup, crocin. Continue. Home remedies, very good. Antihistamine. Syrup Maxtra, steam inhalation, lemon, honey, mosambi. Symptoms, reassurance, good. I'm very happy for those who have typed what you will write tomorrow. I'll tell you. Hats off to you. Solvin, right? Azithromycin, Maxtra, steam, paracetamol, symptomatic reassurance, Timinic, saline nasal drops. No problem. See, there is something called truth. And I know amongst the faculties, if you ask to type, including me, it can be more horrible than what you are typing. More the knowledge, more worse is the prescription. Yes. Counseling, kadda, a kada. I don't know what is kada in Hindi means. Okay, something.
Kada is the
Kadak.
concoction of all the herb, this
Oh
jeera,
my God,
everything
the
on that.
herbal mix. Okay, fine. Plenty of fluids, fine. Salbutamol, antihistamine, normal saline. Okay, continue till I will give one minute, and once the chat stops, I will interact. Chlorpheniramine, CPM plus home remedies. Follow up means you will follow them up to next clinic. We'll go into the next clinic. So my question, as and when you are typing, I'll ask a question to you. Somebody said reassurance. So he has come with a prescription. Dr. Shitanshu Srivatsav, morning to evening, night to morning, open on Sundays also. Everything is typed, correct? Visit the nearby chemist, Lakshmi Medicals, all those things are written. And there is a date and time, correct? Huh? What he will write there? Reassurance. The medical shop fellow will see that and say, what is this here? What doctor has given? Will you send anybody with a blank prescription? Fluids orally, okay. Nebulization with NS every or 3% HS. Explain the cause. Fantastic. I can see, at least Shitanshu, do you agree with me, being co-panelist, there is heterogeneity.
Yeah,
No doubt the
definitely.
patients go from clinic to clinic.
Definitely.
Because if they go from one chat box to another chat box, there is a change. So they feel that somewhere they can get a relief. Zircon, zinc, correct? Do you agree? Vitamin D nowadays, remdesivir, nobody has written remdesivir, Famiflu, talk to patient, nothing is there, right? So now we are happy. We are happy with this. Now, Shitanshu, your comments. Now, there is, what does that mean? There is lot of, I would use in one line, polypharmacy, correct? No?
Yeah.
Truth only, nothing but truth for 5 years, 15 years. Sir, we all trust you. Basically, we want you to write what is there in you, in your heart. Okay. It is no way a criticism. Even you can see my prescriptions, no different from yours. Let me confess and tell you, fantastic. Now, okay. Now, when multiple drugs are there, it only means that nothing works. And with the COVID, one lesson I have learned. More the number of theories and more the number of WhatsApp messages, it only means nothing works. Do you all agree on this point? Type yes if you agree.
Yes, sir.
Type yes. Do you all agree? When there is a polypharmacy, it means that none of them work. This is bottom line. Okay. Next point. Next question is very important. I will tell you there are two types of pediatricians. Now you should be only truthful. Huh? Okay. One type of pediatrician is one who is very brainy. He reads lots of journals, lots of textbooks, professor, ex-professor, emeritus, everything. Understand? He has read Nelson 20 times. And he has hardly any patients in the clinic. It's very rational, no? Naturally, patients will come down. He has very narrow heart. That means he says, hey, cough means no treatment. Go. I told you, na, drink some water and go. Take some sips of water, warm water. That's all. Don't put a pressure on me. Correct? This is called pediatricians with huge brain and very less heart. Okay. Next, I have a different type of pediatricians on the other end. Have huge heart, cardiomegaly and microcephaly. Huge heart means, sir, this little block is there. One, sir, I think this is there. One more. Sir, in the night he coughs more. So you, for the night, you take suppressants. Okay, you want to sleep now. In the early morning, it gets cough. Okay, take an antihistamine. Could be allergic, you will never know. And so if these two does not work, turn your prescription to the next page. So on Monday to Tuesday, you take this. Wednesday, you don't come and trouble me. Thursday to Friday, you take this. And next day, you do whatever you want to do. Correct? This is called cardiomegaly. Now, for fun, let's have some fun here in workshop. You write to which side you belong. B for brain and H for heart. Right now, let's have some fun. We'll see how many of you have B and how many of you have H. B, H, B, H, heart, heart. Okay, good, good. No, it doesn't matter. Okay, H more. Okay, B, here and there we see B. In between somebody is there. Mix of both. Sometimes you will have brain, sometimes you will have heart. Okay, fantastic exercise. What we are trying to do in this module is to, you have brain and heart, both. You can't have brain and only heart. I gave that description, but you have to balance between your brain and heart. Somebody asked me, sir, you tell me what you will do. Then I said only one thing. My brain says don't write a cough syrup, but my heart says write a cough syrup. Correct, no? So you must, those of you who have huge brain, expand your heart a little bit. Yeah, nothing happens. If you write here and there, it's okay. Don't make a patient to go to someone else's clinic. Instead of you writing one syrup, he may write 4 syrups. Did you understand what I mean being critical? This is unscientific advice from me. Take it from me. Only brain is correct. Heart is not correct. Now, what I meant was be practical. Or write something, write sips of water, honey, home remedy, something. But tell them that, suppose if she still pressurizes, what you can do? You can tell her that I will write, but it will not work. You understand my point? I'll write, but it will not work. I'll show you why it will not work. The next part, those of you have big heart, please shrink your heart. It is high time that you shrink your heart. Enough of beatings from patients also. You have shown that big heart. Many of them have come and beaten your clinic also, isn't it? You have been very welcoming, warming. You are the great doctor. They will flatter you and take a prescription and multiple prescriptions out of you. And then, they are sometimes thankless also. For those of them who have big heart, I'm telling, not for everyone. So shrink your heart, expand your brain. So you should have a normal size brain and a normal size heart, and appropriately balanced based on the available evidences, experience, educational understanding of the parents. If you ask me scientifically, there is no evidence of any of the cough syrups. Okay. The first treatment is no treatment. The second treatment is no treatment. Third treatment is no treatment. Fourth is no treatment. 99th is no treatment. 999th is no treatment. 9,99,999 is no treatment. 10 lakh treatment is honey, antihistamines and all that. Did you understand my point? Don't bring it up. Don't glorify just because you read an article in Lancet. A Lancet never says replace honey above all and write it as the number one drug. The first drug is no drug. The second drug is no drug. Third drug is no drug. 100th drug is honey or tulsi, whatever you want to write, or any of the cough syrups you write. Remember, we are going to have a session continued, which will tell you about benefits versus harm. You should weigh the benefits versus harm. In a self-limiting cough, do I all require? Lastly, Shitanshu, if you permit me, Shitanshu and Hema, you will work as volunteers for me. I will demonstrate to them how the cough comes in an acute upper respiratory tract infection. So somebody was asking me, sir, you tell me so much in the module, but how it is possible to counsel a mother? Now, all of us do this exercise. I will not be doing this exercise on my behalf. Hema and Shitanshu will do this exercise. You close your nose. I want all of you from the audience, all of you do this. Close your nose. Take a deep breath. Close your nose. Close your nose. Have you closed? Breathe from the mouth. And breathe. Open the mouth widely, Shitanshu. Open the mouth widely. Now, don't stop. Slowly breathe. Breathe. Hima already got cough. Okay. Continue, continue, continue. Breathe from the mouth. What happens to your throat? Does it get dried? Yeah, Shitanshu got the cough. Audience, tell me, did you get cough? Yes. If yes, type C. If you got the cough. If you didn't get the cough, continue to breathe in the mouth. See what Hima did now. She took a sip of water. That's the treatment. Okay. I will just ask a small question to you. I will give Shitanshu and Hema 1 spoon of dextromethorphan. You imagine that you have taken 1 spoon of dextromethorphan. Okay, Hima. Now she has taken 1 spoon of dextromethorphan. Now you breathe from the mouth. You think that 1 spoon of dextromethorphan taken 20 minutes back, honestly tell me, will prevent you from coughing? Will suppress that reflux? Will it prevent from dryness, irritation, subepithelial stimulation that happens in acute infections? The answer is no. Please do this for all mothers. Make them do this. Produce a cough in them. Don't leave them out of the clinic. And tell them and explain them what cough is all about. Then they will understand. And I've just given you only one mechanism of cough, that is nose block. We did a nose block. Did you understand? You can also mimic irritation also. Fry a chili if you want. Red chili or green chili you fry. You take a spoon of dextromethorphan. I want you not to cough in the kitchen. Is it possible? No. Neither the irritation, nor the obstruction, nor the dryness can prevent or suppress this protective reflex. That's why my first session was very, very important. It's a protective reflex. If you want to come out of the cough reflex, you should be anesthetized. If you want to really treat the cough, tell them, you come to OT, I will anesthetize, charges are so much. Then they will say, no, sir, let him cough. You understand my point? So this is very, very important for you to tell the mother. And then after that also she says, sir, theek hai, fir bhi raat ko kuch hua. Then you write, it's her headache. Let her buy 60 rupees bottle, 100 rupees bottle. But you have counseled enough and you have warned enough. We tell everybody to wear the mask. All of them wear the mask. No. Why you get frustrated? Don't get frustrated. You tell, you will do your job and leave it to them. They will understand. After giving 2 days, they realize that it doesn't work. But they at least don't go to neighboring pediatrician. They don't come back to you asking for change of syrup. They will not come back to you asking for an antibiotic. This is the point that you need to analyze. Did we make this concept of what you have to tell and how to avoid, basically how to avoid over-the-counter drugs and cold and cough syrups? If you have all been happy, type H. Type H if you're happy. If you're not happy, I'll continue to breathe through the mouth. Are you happy? H, yes. Oh, somebody is more happy, very happy. Okay, good, fine. So that was just to see that you are all awake. Okay, don't worry. Fantastic. Now, can I ask Shitanshu, you can continue with the session with you and Hema. Now, Shitanshu, I request you to tell the audience. Yes. Now you tell everything about cough syrup the way you are going to tell to the mother. No problem. Let them have a complete knowledge of the cough syrups, isn't it? Okay.
Dr. Hema, I think she will continue.
Yeah, Hema will continue. Hema, please continue.
Okay. Thank you so much, sir. So I think we had an interesting session that when a mother brings to us a child who's coughing, that what we have to exactly do. So we were in dilemma that what are the pharmacological methods and the non-pharmacological. So I think it has already been summed up. So talking about the pharmacological methods, the cough syrups and all, if we think about it. So we know that expectorants or the mucokinetics, which we have been using in bronchial secretion enhancers, like there may be sodium or potassium citrate, potassium iodide, guaifenesin, balsam of Tolu, Visaka, ammonium chloride, which we all see in a lot of cough syrups, or they can be mucolytics. Can we go back to the slide? Or we can have a category of mucolytics, which include bromhexin, ambroxol, acetylcysteine, or carbocysteine. So next slide, please. So then we have a category which is antitussives, which are cough center suppressants, which may include the opioids like codeine, ethyl morphine, or the folcodeine. Then we have the next category as non-opioids like non-noscapine, dextromethorphan, and chlorpheniramine. We have another category in which we have antihistaminics like chlorpheniramine, diphenhydramine, or promethazine. And then we have the peripherally acting one, the phenoxydiazine, which may be there. So we all see that the cough syrups have all these things. Then we have the antihistaminics, which can be H1 antihistaminics, which we normally use. They afford relief in cough due to the sedative and the anticholinergic action. They lack selectivity for the cough center. They are promoted for cough in respiratory allergic states, like we all know in asthma. Then we have a second generation antihistaminics. We know that they are ineffective for cough. Then we have another category where we are confused with montelukast and cetirizine combinations. So we all know that these combinations are not approved and for acute cough. They might be indicated in some cases of asthma, but combinations are a total no. They are either not pharmacological or they are not either pharmacokinetically they are approved. Next slide, please. So now, what are the adjuvant drugs which we most of us have a tendency to use? Some of us have a tendency to use bronchodilators like salbutamol or terbutaline. So what about when they should be used? Bronchodilators should be used only when there is an element of bronchoconstriction is present and not routinely. Most of us tend to use them that the child may have some amount of element of this, but they should be judiciously used. Then we have a oral beta-2 agonist therapy. This should be strictly reserved for patients who cannot correctly use inhalers or as an alternative or adjuvant drugs in asthma. So these are reserved drugs only to be used when we know that there is a different amount of bronchospasm in characteristic conditions like asthma or in certain other cases. Next. Now coming to the cough syrup mixture, as we all have seen in the previous mimicry that we all have written so many names. So fixed dose combinations of expectorants, antitussives and bronchodilators, they are available widely, but they are not satisfactory because of difference in the time course of action of the components and liability of indiscriminate use. So most of the components, like we have said, that montelukast and cetirizine, they are not a very good pharmacodynamically or a pharmacokinetically very not good combination. So these should never be used. Fixed dose combinations of a centrally acting antitussive with a bronchodilator or with an antihistaminic have been banned in India, but they are still marketed despite this because of the poor knowledge. Next. So what should be prescribed? Robust evidence is lacking in children that there is any use of these anti-cough medications or not. Dextromethorphan is the only drug which is approved, but it is limited for unusual circumstances like severe prolonged cough, which is interfering with feeding or sleeping. So all these cough mixtures actually go out. We don't have to prescribe. The reserved drug is dextromethorphan in certain conditions only. Opioids are an absolute no. Dextromethorphan also in children less than 2 years, it is not indicated. Next slide. Next, coming to steroids. As we all know, when nothing works, steroid works. And even in COVID, we have been seeing the uses of steroids. So whether this should be used in acute cough, the steroid options can be prednisolone, deflazacort, hydrocortisone, which are widely available and widely used. So there is no efficacy of acute cough of use of steroids. So chronic cough is a different thing, but in acute cough, there is no role of steroids. However, potential side effects are well known. So we should say no to steroids. Maybe by doctors or parents, we don't know, but it is not recommended. Role of nebulization in acute cough. Should we nebulize a child? So nebulization is limitedly prescribed in conditions like croup or in acute asthma exacerbation. Beyond this, there are not much indications of nebulization, whatever you want to use. The dictum is nebulization is less effective in other etiologies of cough. So this is reserved in conditions of beyond these two. Next. So now let us coming to the home measures or the home remedies, which most of us write in the prescriptions, whether it is honey, ginger, lime water. Some may use steam inhalation, using oil massage, the herbal mix of tulsi. Some others ask for saline gargles. Then there can be other things like camphor, methanol, and chest rubs, the Vicks which we commonly use and is most commonly notoriously used in North India. So there is lacking of evidence of all these uses. In fact, some of them have shown to have a disadvantages also, like using steam inhalation in small child can cause burns in the child, and it can cause drying of the mucosa rather than doing any positive thing. Again, things like camphor and methanol and all can cause severe irritation in children if they are used on large surfaces and for multiple times. So all of them may have some action like honey and ginger. Maybe some people may say that it used to work for our grandparents and my mother also used for us. But again, we all know that there's no evidence scientifically for them. Next. Next slide. Okay. So now let us come to the condition. So we have seen that we don't have to investigate the child. We don't have to prescribe the child. So how do we manage this child? Most of us, 80% of the patients come with this complaint. So the most important thing would be counseling in this parent. So the counseling is the most important action. It bring back the child if there is no. We have to tell the mother that you have to bring back the child when the child has these danger things, that the child has fast breathing, the child has difficulty in breathing and is not able to drink or feed, and the child looks sick. So we have to very importantly tell mother that you can keep the child at home and bring the child back only when these things are there. Parents should be counseled about the natural history of cough. We should tell them that this cough will remain for longer time, or maybe 2 weeks and maybe up to 4 weeks, and they don't have to give any medicines for this. Educating the parents will allay the anxiety. Most of us know that anxiety is the main component in parents which brings them to us. So we have to tell them, explain them about the disease and the course of the illness which will be there, which will decrease their anxiety, and then patient and doctor, and avoid the polytherapy. And this will also avoid the doctor switching or the shopping, which is normally done by the parents. So I think the one word about acute cough management would be counseling and educating the parents about the cause of the disease and to tell them about the what would be the red flag signs. Next slide. Next slide. So the red flag signs in acute cough would be, in history, we have to ask the mother that whether it is a sudden onset cough with choking, which may indicate foreign body, especially in smaller children, whether there is any associated failure to thrive, which may actually suggest more of a chronic etiology. Is there any associated hemoptysis? Neonatal cough is definitely an alarming sign. Are there any swallowing difficulty? Is there any shortness of breath which is there? Then on examination, we may look for hypoxemia, which is present or not, whether there is any tachypnea or retractions, which is there. We have to look for other etiologies like cardiac murmur, which is present. We may look at the chronic hypoxia and clubbing, which is there, and whether the child has altered sensorium. So we have to tell the mother about all these things, that she has to carefully look at the child and have to bring back the child if these signs are present. Next. Next slide, please. So the take-home message for acute cough would be, evaluation of the origin of acute cough is important for therapeutic decision-making. So we know that what is the origin of the cough, whether it is the upper airway or the lower airway. Then investigations are not needed in most of the cases of acute cough. Foreign body is an exception, where it might be a direct indication for bronchoscopy and any other thing. Management and etiology driven, mostly to afford a symptomatic relief. Home remedies are overhyped. There are no scientific evidence for that. Combination of cough syrups, there are no beneficial role for them. Antibiotics are only in bacterial etiologies. So the take-home message would be, parent counseling is the most important component of management of acute cough, which we all learn, that how to take sips of water and what all to tell the patient. Next slide. So I think now again we can break for an interactive session. Thank you.
Sitanshi, if you can stop sharing the screen.
Yeah, sir.
Okay. Now this is a break session. I think you need breaks, isn't it? Sitting continuously in any webinar would be very difficult. You have gone through sessions of basics of cough, then acute cough, pharmacological, non-pharmacological, home remedies, so on, so forth, everything fine. But what happens in real life situations? Correct? We must have done everything. Somebody has even typed appropriate counseling, reassurance, this, that, etc. What is that secret reassurance that you do in your clinic is exactly what we wanted to know. So fine, shall we go ahead to see? Now I have a wonderful scenario here. That is, I request all the panelists to mute yourself, mute your videos also. Mute your videos as well so that, you know, myself and Shitanshu are seen. I request all the panelists, please. Right. Now, the scenario is quite simple. Dr. Shitanshu is a very busy pediatrician in Delhi. Which part of Delhi is very busy? I don't know. Is it Connaught Place? Okay, fine.
Rohini,
Then,
sir, Rohini.
okay, fine, ma. Fine, fantastic for that input. Now, she's like, she's God. Everybody wants to just once we should see Shitanshu and come back. Then we are fine. No matter any number of pediatricians tell whatsoever, we should see once Shitanshu, and if she says wait, we'll wait. If she says treat, we'll treat. If she says investigate, we'll investigate. To that extent, she has established herself in that part of Delhi. Now the issue is simple. I'm the mother, troubled mother, who has heard that Shitanshu is a very popular pediatrician, and I have been showing to her. But because she is very famous, I don't want to change. But now I'll enter her clinic, and this is exactly what happens in real life scenario. मैं अंदर आ सकता हूँ बहन जी?
आइए बहन जी, अंदर आइए।
अरे आपका क्लिनिक छोड़ के कहाँ जाएंगे हम?
आइए, आप बैठिए। बच्चे बच्चे बबलू इधर बैठो।
बैठना तो है हमारे लिए, पर कितने बार आ चुके हैं हम आपका क्लिनिक छोड़ के। आपने देखा क्या किसी और के पास मैंने कभी गया क्या?
हाँ बहन जी, आप पहले बैठो, फिर सारी दिक्कतें बताओ। मैं सारी दिक्कतें सुनूंगी। हाँ बताइए बहन जी, क्या दिक्कत है?
आप सुन रहे हैं मैडम? कितने बार सुन रहे हैं हम एक ही शिकायत है, हम बार बार आ रहे हैं। कितने बार है? अगले पिछले हफ्ते आया था मैंने, सामने वाला 300 भरने के लिए बोला, मैंने भरा। अभी खांसी के लिए आया था, खांसी कम नहीं हुआ। और लास्ट मंथ में भी 3 बार आया मैंने, और आपने तो सिर्फ 7 दिन के लिए फ्री रखे है मेरे लिए। तो हमारे लिए थोड़ा देखो। 4 बच्चा है मेरा, ये दूसरा वाला अभी खांस रहे। वो पिछले वाला को तो मैं पहले वाला को मैं लास्ट टाइम दिखाया था, वही दवाई डाला, 3 दिन से कम नहीं हुआ जी। और इतना खांसता है जी, मेरा जी भर के मैं तो मर जाऊं। आज तो मेंटल डे है, मैं तो मेंटल हो गया हूँ।
खांसी के साथ और क्या दिक्कत है? बुखार भी आता है या कोई और?
नहीं मैडम वो दूसरा मत पूछिएगा मेरे को, सिर्फ एक ही पूछना। इसको खांसी है, खांसी ठीक करना मेरे को, मैं इसीलिए तो आया हूँ।
अच्छा ठीक है,
इधर आजा,
बैठाइए इधर।
बेटा इधर आजा, डॉक्टर के सामने बैठो।
अच्छा, अब बच्चे को हम थोड़ी सी जांच करेंगे। बेटा इधर बैठो, स्टूल पे
नहीं मैडम मेरा बात सुनिए। बच्चे को ये रोहन, जरा डॉक्टर के सामने 1-2 बार खांसी कर ले। घर में इतना खांसता है, इधर बैठ के चुपचाप बैठा है। देखो मैडम, घर में इतना आवाज करता है, इधर
मैं समझ रही हूँ कैसा
1-2 बार खांसी कर ले, डॉक्टर भी देख ले।
चलिए, अच्छा इसने खांस दिया, अब इसको यहाँ बैठाइए, अब हम इसको देखते हैं। बेटा मुंह खोलो।
मैडम सुनिए मेरा, आप हमेशा देखते रहेंगे। देखो मैंने एंटीबायोटिक दिया, हमेशा एंटीबायोटिक देने के बाद ही वो ठीक होता है। मैंने पैरास्टामोल दिया, सुबह को आपने अक्टूबर में लिखा था ना, अजीब कुछ तो था, वो दिया। एक एस्कोरिल करके था, घर में पड़ा था, आधा बॉटल पड़ा था। मेरा घर में आके देख लीजिए, मेरा आधा कबोर्ड, कंप्लीट कबोर्ड भरा हुआ है। मैं एक्सपायरी तक नहीं देख सकता हूँ। सब आपका लिखा हुआ है, मैं दुकान से नहीं लाया हूँ, सब आपका लिखा हुआ है।
देखिए एक चीज बहुत अच्छी, बच्चे के लिए बहुत परेशान है, आप चाहती बच्चा ठीक हो जाए, बहुत अच्छी बात है ये। अब जो हम आपको कुछ चीजें बताएंगे, पहले हम बच्चे को एक बार जांच कर ले, फिर हम आपको आगे बताते हैं आगे क्या करना है। आप थोड़ा
मैडम मेरा और एक बात सुनिए।
हाँ बताइए।
अभी मेरा हस्बैंड है ना, ये मेरे को इतना डांट पड़ा है, हर बार तेरे को पैसा देता हूँ, तू कम
अच्छा,
अकल
तो
वाली है।
खांसी के साथ ये भी एक दिक्कत है।
नहीं खांसी के साथ नहीं, मेरा बात सुनिए। मेरा हस्बैंड बोलता है तुम कम अकल वाली, क्लिनिक को जाती हो, मैं तो पैसा तुमको देता हूँ, डॉक्टर के सामने अच्छी तरफ से क्लियरली क्या है कुछ नहीं बोलती हो, जाती हो, डॉक्टर जो बोलता है ऐसा हाँ करके सुन के वापस आ जाते हो, दवाई लेके आते हो। और तुमको भी नींद नहीं, तुम तो पागल हो, मेरे को भी नींद नहीं। मेरे को
आपका हस्बैंड बोलता है तो एक काम
हस्बैंड को भी दवाई दे दीजिए, मेरे को कोई बात नहीं। क्या करो जी, मैं थोड़ी परेशान हूँ, घर में उनका भी डांट। आपका तो एक दो अच्छा बात 2-3 मिनट के लिए सुनते हैं, पर बाकी 24 तास मेरे को घर में गुजरना पड़ता है। देखो जी, ये बार मैं देख रहा हूँ, मैंने सुना है पहले पे कहीं पे और नया और एक डॉक्टर है, सब लोग ने बोले उधर जाओ करके। मैंने बोला फिर से आपको बहन जी
परेशान
के
नहीं
पास
होइए,
एक बार
हम
लेके
आपको अब आप आपकी जितनी भी दिक्कतें हैं, सारी परेशानियों का हम आपको सबका इलाज बताएंगे क्या करना है।
अभी
पहले
एक मास्टर दवाई दीजिए, मैं चाहिए तो और 300 रुपए भरूंगा।
नहीं नहीं, पैसे नहीं
पैसा
लगेंगे।
दवाई लिख दीजिए ताकि
अभी
मेरे को एक खांसी बंद हो जाए।
अच्छा बेटा, मुंह खोलो अपना, ठीक है। छाती, कपड़ा ऊपर करो, छाती देखनी है, कान इधर करो। अच्छा, बैठ जाओ, इधर बैठो। बहन जी देखिए, ऐसा है, छाती एकदम साफ है बच्चे की, नंबर
अरे
1।
क्या बहन जी, आप मैडम क्या बोल रहे हैं? छाती साफ है और काशी
छाती
इतना
साफ
बड़ा
है।
है, ऐसा कैसा हो सकता है?
अच्छा, पर खांसी आ रही है, पर खांसी आ रही है ना, आपने जैसा बल्लभ बताया, खांसी आ रही है।
छाती नॉर्मल है और काशी कहाँ से आ रहा है मैडम?
हम आपको बताएंगे क्या हो रहा है अभी। दूसरी चीज, गला भी साफ है, गले में भी कोई सूजन नहीं है, टॉन्सिल्स नहीं बढ़े हुए हैं, और
कुछ नहीं,
कान भी ठीक है।
ना इधर से ना उधर से, बट कहाँ से?
अच्छा, अब हम एक आपको कुछ करने को कह रहे हैं, आप करो बहन जी। अपनी नाक बंद करो, मुंह खोलो, करो ऐसे जैसे आप कर रहे हैं, नाक बंद करो, मुंह खोलो अपना।
मैं करता हूँ मैडम, पर ये करने से बच्चे का काशी बंद हो जाएगा क्या?
नहीं, अब हम आपको बता रहे हैं, आप बस करो, अभी आपको खुद समझ में आ जाए, आप इतनी समझदार हो, आप खुद समझ जाओगे। करिए,
ठीक है।
इसको करिए
अब
बहन जी, ऐसे करिए, नाक बंद करिए,
10
मुंह
साल से
खोलिए।
मैं आपका बात सुन रहा हूँ करके मैं कर रहा हूँ।
मुंह बड़ा खोलिए, मुंह बड़ा खोलिए और सांस लीजिए।
कितना मिनट करना है मैडम?
हाँ, आप सांस लेते रहो जब तक आप हाँ, जब तक दिक्कत ना हो, सांस लेते रहो।
थोड़ा पानी है क्या आपका
हाँ
क्लिनिक
हाँ,
में?
ले लीजिए, पानी लीजिए, हाँ
अच्छा
पानी
वाला?
लीजिए। हाँ हाँ,
अच्छा,
अच्छा है।
अच्छा वाला पानी है क्या?
हाँ हाँ, फिल्टर का पानी है, ले लीजिए। अभी बहन जी आपको क्या हुआ, आप ये बताओ, अभी क्या हुआ?
मेरे को परेशानी हुआ, बच्चे बच्चे से मेरे को भी काशी हो गया करके मेरे को दिमाग खराब हो गया अभी।
और आपने जब पानी पिया तो क्या हुआ? नहीं, पहले पानी पीने से पहले क्या हुआ, क्यों खांसा, आपको क्या लगा, मुंह में क्या लगा, अंदर
गले में किचकिच,
किचकिच लगा, और क्या लगा, सूखा सूखा लगा मुंह के अंदर?
सूखा लगा, बहुत ड्राई हो गया।
बहुत ड्राई हो गया, फिर आपने क्या करा उसके बाद?
थोड़ा पानी पिया ना, आपने दिया ना पानी।
पानी पिया, फिर क्या लगा, फिर क्या हुआ आपको?
थोड़ा थोड़ा जी भर गया मेरा।
थोड़ा सा आसानी हुई।
अच्छा,
तो
ठीक है ठीक
अब
है।
हाँ, थोड़ा सा आराम मिला आपको? आप
थोड़ा
दोबारा
आराम
पानी
मिला,
पीना
थोड़ा
चाहोगी?
आराम मिला,
आप
थोड़ा
दोबारा
आराम
पानी?
मिला जी, थोड़ा
हाँ
आराम मिला।
हाँ, थोड़ा आराम मिला। तो ये देखिए, बच्चे का हमने जब इसको एग्जामिन करा, छाती साफ है, गला साफ है, कान ठीक है, तो दवाइयों की जरूरत के बिना आपको, अगर बच्चे को पानी आप बार बार पिलाओ, गुनगुना पानी भी पिला सकते हो, तो बच्चे को खांसी में राहत मिलेगी। तो आपको ये ऐसा लग रहा है कि ऐसा करने से कुछ फर्क पड़ेगा?
नहीं, मेरे को तो फर्क पड़ा, घर में इतना बड़ा सिरप पड़ा है, वो सब पानी है क्या?
वो देखिए, उसकी एक्सपायरी भी हो सकती है, तो पुरानी सिरप तो आप एकदम मत दो, उसको सब हटा दीजिए आप, है ना, अभी के लिए हटा दीजिए, अभी बच्चे को कोई जरूरत नहीं है उन दवाओं
ठीक
की।
है।
पर हम
सब
एक
वेस्ट हो
चीज
गया,
आपको,
इतना सारी पैसा मैंने खर्चा किया मैडम।
पर ये तो देखिए बहुत जरूरी चीज है, आप खुद चाहते हो ना कि आपका बच्चा ठीक हो
मैडम
जाए।
2 दिन के बाद एग्जाम है, एंटीबायोटिक एंटीबायोटिक जो आप पिछले बार बोले थे वो लिखना है तो लिख दीजिए।
अच्छा, आप चाहते हो कि बच्चे को हम ऐसी कोई दवा दे जो उसको नुकसान भी कर सकती है, क्या आप चाहते हो? तो हम लिख भी सकते हैं,
नहीं
क्या
नहीं
आप
नहीं 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 नहीं, बच्चे को नुकसान नहीं होना मैडम।
नहीं होना चाहिए
ये
तो?
तो आपके पास आए।
हाँ, इसीलिए देखिए, हम इस पर्चे पे कुछ और चीजें लिख रहे हैं कि कुछ रेड फ्लैग साइन होते हैं। अच्छा, एक बात बताइए, बच्चे की पसली चल रही है, आपको लगता है कि कभी घर में खांसता है तो पसली चलने लगती है, शराब में चलने, ऐसा होता है?
नहीं
सांस
नहीं नहीं
फूलती है, पसली नहीं चलती, बुखार आ रहा है बच्चे को?
नहीं, बुखार थोड़ा सा था, दवाई देने के बाद ठीक हो गया
ठीक हो
मैडम।
गया। अच्छा, और सुस्ती है क्या, बच्चे के खेलने में कुछ कमी है?
अरे बदमाश है मैडम, वो मेरा हस्बैंड एक बदमाश है, ये और बदमाश है।
अच्छा, और खाने पीने में कोई कमी हुई है?
ये खांसी खांसी करता है, थोड़ा बुखार है तो दूसरे को मारता है।
हाँ, तो देखिए, खा भी पी, तो ये सारी चीज, अगर इनमें से कोई भी चीज होती है तो आप तुरंत लेके आए, मैं फीस भी नहीं लूंगी आपकी, और बच्चे का दवा लिखूंगी फिर।
अरे ये दोबारा बोलिए, मेरे को सुनना है वो।
हाँ, अब नहीं लूंगी, क्योंकि एक ही बीमारी के लिए आप दोबारा आओगे तो फीस नहीं लूंगी मैं, है ना? तो
वो तो बार बार आएंगे हम, हमारे हमको को अच्छा हुआ कि क्या करना है, पानी पिला के आना है कि ऐसे ही आना
हाँ,
है?
आप पानी घर में भी कई बार पिलाओ बच्चे को जब भी खांसी आती है। और देखिए बहन जी, एक आप बहुत समझदार हो, मुझे पता है कि आप समझ गई हो, ये जितनी
ठीक
भी
है।
चीजें मैंने बताई हैं ये आप समझ गए, और आगे भी जो और लोग हैं, आप औरों को भी ये समझा सकते हो। हमने पर्चे पे लिख दिया, अगर कोई भी दिक्कत होती है इनमें से कुछ भी, तो आप तुरंत बच्चे को मेरे पास लेके आओ, तब मैं इसमें दवा लिखूंगी।
ठीक
अच्छा,
है
मैं
मैडम, मैडम वो रिसेप्शन वाला ने मेरे को एक चिट्ठी दिया, डॉक्टर के पास दवाई लिख के आ जाओ, इसमें दवाई लिख देंगे।
हाँ, तो हम
अभी
इसमें
जो
लिख
लिखना है
देंगे,
लिख दीजिए।
हाँ, तो हम इसमें ये लिख रहे हैं कि अगर बुखार आता है तो SOS बेसिस पे आप बुखार की दवा दे सकते
ठीक है।
है ना। और इसके अलावा और कोई दवाई की रिक्वायरमेंट अभी
नाक बंद होता है, वो रात को गोर करता है।
अगर नाक बंद होती है तो नाक में आप ड्रॉप्स डाल सकते हो, वो हम लिख दे रहे हैं। अगर आप लेना चाहो ले लो ये। और धीरे ये हमने इसमें लिख दिया है 1 से 2 एक बूंद दोनों नाक में।
मैडम और एक बात बता दीजिए, 7 दिन में आपका फीस खत्म हो जाएगा, कितना दिन रहेगा
ये 2 से 3 हफ्ते रह सकता है।
नॉर्मल है फिर भी?
हाँ नॉर्मल है, ये नॉर्मल है। और बच्चे का क्योंकि कोई और छाती में कोई दिक्कत नहीं है तो कोई
मैडम दोबारा बोलिए, कोई बड़ा बीमारी तो नहीं है ना?
नहीं, इस समय कोई बड़ी बीमारी का ऐसा कुछ भी लक्षण नहीं है बच्चे को।
कुछ
कोई
टानिक वानिक लिखना है तो लिख दीजिए, दोबारा एक खांसी ना आ जाए।
देखिए इसका वजन कराया है हमने और वजन इसका बहुत अच्छा है, तो इसको टॉनिक की भी जरूरत नहीं। तो आप अच्छा है ना, आपके बच्चों को दवाई की जरूरत नहीं है, तो आपके लिए अच्छी चीज है। और हम ये भी कह रहे हैं कि अगर कोई दिक्कत होती तो आप दोबारा जरूर आइए। हमने इसमें नंबर भी लिख दिया, फोन नंबर भी लिख दिया और ये साइंस लिख दिए। कुछ साइंस है कि पसली चलना, बुखार आना, सुस्ती आना, तो आप तुरंत हमारे पास लेके आइए।
ठीक है मैडम।
नमस्कार।
तो ठीक है, तो फिर अच्छी बात है। तो हम मेरा आजू बाजू वाले को बताएंगे।
जरूर बताइए, ये बहुत आप बहुत समझदार हो, मुझे लगता है आप औरों को भी ये बात बताएंगी तो इससे औरों का भी उसमें वृद्धि होगी। अननेसेसरी दवाइयां नहीं चलेंगी बच्चों की।
थैंक यू मैडम। फिर सब हम चलते हैं मैडम। शुक्रिया, भगवान आपको बहुत अच्छा लंबी उम्र दे।
धन्यवाद।
मैं तो हमेशा रोज मेरे बच्चे को के साथ साथ आपका भी अच्छा करे करके बहुत बार प्रार्थना करता हूँ। थैंक यू मैडम, मैं चलूं?
हाँ हाँ धन्यवाद, नमस्कार।
थैंक यू। So my dear friends, just can you clap for Shitanshu? CLAP, type CLAP. She can't hear you. She's smiling pediatrician. So she should see. She has got very less for a wonderful pediatrician with lots of patience and a wonderful explanation she could do for you, isn't it? So all of Shitanshu, you have wonderful claps from all of them.
Thank you so much, sir. It was all your guidance.
Okay,
But
thank
I
you.
think that listening and the learning skills are very important because we don't listen. We only preach. So the listening skill is also important.
So if you listen to them, half of the times it is done. Then interrupting them,
because they want to be heard.
that forces us to write some antibiotics or some cough syrups. Just because we don't listen to their problem, lot of things happen, isn't it?
Yeah.
Fine. I think this would come to end of this session. So we finish with the role play, and we will go to the next session. Shetansh, if you could share the screen, I will know where I have to leave it for Dr. Kabra, sir. Just for a while, for me to know that the session is complete. Somebody has written Bangalore Hindi. Delhi का हिंदी अलग होता है क्या शीतांशु? No, unmute. Okay. Now we will go. You can stop sharing the screen. Dr. Kabra will take over from here. Stop sharing the screen. Dr. Kabra, sir. Shitanshu, you can stop sharing the screen.
Before moving to, I want some comments from the chairperson also.
No, we'll take it up. I'm just winding up this session. The next session will be from Kabra and from the chairpersons next. So thank you all the chairpersons from all three of us. Hima, if you want to hand it over to chairpersons.
Dr. Manish, you want to say something? Dr. Manish, you want to say something, sir? Dr. Manish Gupta. Sir, you are not audible. I think there is some problem with audio. So, Dr. Smita Mishra, the secretary in Delhi, to announce the next session and to introduce the chairpersons.
ये नहीं बेटा
देखा
Dr. Smita?
Dr. Arun. Hi, good afternoon, everyone. Now, let me introduce Dr. Arun Garg. He is graduate and postgraduate from PGIMS Rohtak. He is practicing general pediatrician with special interest in respiratory diseases. And he is Vice President IAP North Delhi 2020.
I also request Dr. Smita to introduce our next chairperson, Dr. Vineet.
Dr. Vineet Sehgal. His present designation is consultant pediatrician. Present affiliation is office practice, Max Super Specialty Hospital, Shalimar Bagh, Delhi. His areas of interest are pediatric respirology and long distance running. Long distance running. He is our champion. The positions he held is master trainer of IAP module ATM, ARCTM, RTIGM. He was president of Pediatric Respiratory Society, Delhi. Past secretary of IAP National Respiratory Chapter 2015 to 16. So, Dinesh, next.
Yeah. So now I request Chairperson Dr. Arun Garg to introduce Dr. Kabra sir. Although he doesn't need any introduction, but sir.
Thank you, Dr. Smita, and thank you, Dr. Dinesh. From pathology of cough to acute cough, and now we move on our module to chronic and recurrent cough. And for this, I invite Dr. S.K. Kabra, Professor, AIMS, New Delhi. Dr. S.K. Kabra has a huge CV, but for the benefit of our august audience, few of his credentials are: he's editor-in-chief, Indian Journal of Pediatrics, and a special research interest in cystic fibrosis, asthma, tuberculosis, diagnostics, as well as ARI. Sir has more than 550 publications and 170 chapters book. Besides this, he has a lot of books also. To name a few, they are Essential Pediatric Pulmonology, AIMS PICU Protocol, Case-Based Research Pediatric Pulmonology, and many more. Over to you, sir. Thank you.
अच्छा आइडिया है ना मैंने इसमें से वो अनस्टेबल हो रहा था ना मैंने इसे डायरेक्ट वो कर लिया है ना
Okay, good afternoon, friends. My slides are visible?
Yes, sir.
And I am audible?
Yes,
okay. So, in next 35 minutes, which has been allocated for the chronic and recurrent cough, I'll try to explain you what are the causes and what should be approach for management of these patients. So, what is definition of chronic cough? It is defined as a daily cough for at least 4 weeks. This will be a chronic cough. And this is based on the natural history of any upper respiratory viral infection. However, if there is an underlying illness, then it requires a careful assessment. So if we see total cough, spectrum of total cough, then normal and expected cough is the significant chunk, and that will subside and doesn't require any specific treatment. There is a big chunk of non-specific and specific cough. So what is this specific cough? Specific is when you get some clue from some history examination and then you have certain diagnosis. And non-specific is despite your good history and examination, you are not able to find a particular cause. So let us see what are the specific cough. So specific cough is a child who is having a chronic cough. It is associated with wheezing and other atopy, meaning thereby atopic dermatitis, or it may be a rhinitis. Then you will say that I am dealing with asthma. So here it is more of a just to identify whether a chronic cough is having a wheezing and other atopy. So that history should be asked. If a child is clearing throat repeatedly and there is an allergic salute, then it is a post-nasal drip secondary to allergic rhinitis. If it is a wet and productive cough, in that situation, Any wet cough which is persisting beyond 4 weeks, even after upper respiratory viral infection, should be investigated. And some of the causes are cystic fibrosis, primary ciliary dyskinesia, and protected bacterial bronchitis. We'll be discussing a little bit about these, when to suspect and how to make a diagnosis. If there is a choking while feeding, then it is a recurrent aspiration syndromes, and that we'll be discussing what are the causes and how to investigate them. Then if there is a brassy barking cough, then it may be a malacia, maybe bronchomalacia, maybe tracheomalacia, maybe laryngomalacia. If it is a progressive cough associated with weight loss and history of contact with TB patient, then we will consider that whether I'm dealing with tuberculosis. Specifically in our country, if any child having a cough which may be wet or dry, which is unremitting, going on for more than 2 weeks, TB becomes one of the differential diagnoses. If it is a dry cough, breathlessness, restrictive pattern in spirometry, then you may consider interstitial lung disease. And if cough is a bizarre, disappears during sleep, then it is more of a somatic or maybe a habit cough, and that needs investigation. It doesn't mean that once you have diagnosed this thing, habit cough, then it doesn't require any treatment. It requires a counseling and discussion with the family. So what happens if it is a non-specific cough, like you are not able to identify any pointer? Then isolated cough, otherwise well child. So you will see whether child is well. If it is it cough truly troublesome? Troublesome means it is disturbing his day-to-day activity. It is causing frequent vomiting. It is disturbing his schooling. Then it will require other group of investigation. But if none of these are there, he is coughing, as Subramania said, that 11 times cough may be normal in a child. If otherwise he is fine, he is taking part, he is growing well, search for environmental factors like tobacco smoke, mother, father, or grandparents, polluted air exposure. If none of these are there, and this is a group of children who may have some cough, but no other major issues. In those situations, just reassure parents and follow up after 2 weeks. So if any of these things are there, it is troublesome. It means we have to give some treatments. Troublesome means it is affecting his sleep, it is affecting his activity, it is affecting his growth, if it is affecting his school, and you are not able to find that it is not a wet cough, then give a course of asthma medication. And that is all of you are aware that the asthma medication means inhaled corticosteroids. And then see if there is an improvement. No improvement, stop medication, and then he'll require a further investigation that we'll be discussing in next few slides. If it responds, say after 8 weeks, you may stop it between 8 to 12 weeks. And if there is a recurrence of symptoms, then you restart, and this confirms that you are dealing with asthma. If it is a wet cough which is persisting beyond 4 weeks, then consider that it may be a protected bacterial bronchitis. Give antimicrobial for 2 weeks. If it responds, then you are reasonably sure that it is a protected bacterial bronchitis. More details we'll be discussing in next few slides. So what should be our approach? Define etiology by history, cough pointers, X-ray, spirometry, if available. Define exacerbation. What are the exacerbating factors? Define effect on the child and parents, and then decide. After all these good history, examination, cough pointers, X-ray, spirometry, this is for chronic cough. And then just see what increases the cough. Then you have to identify that yes, it requires investigation, or you can just wait and watch. So if further investigations are required based on these 4 factors, you go for a further investigation. But if you feel that as of now, we can wait and watch because child is otherwise okay, then follow it after 2 to 4 weeks. So examine and evaluate presence of specific pointers, cough characteristics, chest radiograph abnormality, and spirometry. If any of these are not there, then evaluate for the tobacco smoke and other pollutants, child's activity, parents' expectations and concern. If non-specific cough, watch, wait, and review again. And if it is a significant problem, then trial of therapy, review for 2 to 4 weeks. If there is an improvement, then you give label it as asthma. And if there is no review, no improvement, then you will call after. So keep them in follow-up rather than saying that your child doesn't need any treatment, because many a time you may be able to identify some pointers on follow-up. So specific cough, if it is a dry cough, then it is asthma. If it is a wet cough and the child is having just the 4 weeks or a few weeks of wet cough, then you can give a 2 weeks of antibiotic. If it resolves, then you say that it is a PB, protected bacterial bronchitis. And if it is persisting, then it may be a bronchitis. Think of like even after giving 2 weeks of antibiotic, improves or it persists, improve and it recurs or it persists, then think of various other conditions like bronchitis, recurrent pneumonia, aspiration syndromes, chronic or less common infections like chlamydia, mycoplasma, or some viral infection, interstitial lung disease. Interstitial lung disease will cause a persistent wet cough only in an advanced stage when there is a bronchitis. Then airway abnormality, as you had seen, maybe malasias, and then always keep a possibility of cardiac causes. So to again summarize, what are the common pulmonary causes which may give rise to a chronic cough? Asthma, post-infectious cough, sometimes may continue for 4 weeks, pertussis, eosinophilic lung diseases, tuberculosis and other chronic infections which should be kept carefully in our country, chronic suppurative lung disease, bronchitis, cystic fibrosis, or some irritative non-infective bronchitis like smoke and pollutant in the family or in the environment, and recurrent infections. Rarer pulmonary causes, they include interstitial lung disease, protected bacterial bronchitis, primary ciliary dyskinesia, recurrent aspiration like laryngeal cleft, tracheobronchial fistula, maybe swallowing dysfunction, and structural airway abnormality, immune deficiency, or foreign body aspiration. And you can see that extrapulmonary causes are a lot of other causes which may be not related to airways and lungs, like cardiac diseases, habit cough, maybe gastroesophageal reflux disease, maybe mediastinal mass which is causing compression, medications like ACE inhibitors. If your child is getting it for some other purpose, either it may be hypertension or it may be for nephrology diseases or autogenic cough. So now individual condition like what is protected bacterial bronchitis? It is probably a misdiagnosis in our country as of now. Not yet we are giving more label of these BBB. It is when a child is having more than 4 weeks of wet cough and the lower airway secretions like sputum or bronchial lavage shows a colony count of more than 10⁴ of a single microbial agent. Most of the time it may be Haemophilus influenzae. Cough resolved following a 2 weeks course of an appropriate antibiotic. So it is you are doing a microbiology based case definition and treatment. If it is not possible, it remains same, presence of wet cough for 4 weeks, no pointers, and absence of symptoms or signs, specific cough pointers suggestive of other causes of wet or productive cough, cough resolved a 2 to 4 weeks course, or an appropriate oral antibiotic. So this is a protected bacterial bronchitis. Protected bacterial bronchitis, resolution of cough and with antibiotic treatment with 2 weeks, absence of alternative etiology, and treatment is antibiotic for 2 weeks, specifically amoxicillin clavulanic acid. So a little bit about cystic fibrosis, when to suspect. During neonatal period, delayed passage of meconium, meconium peritonitis, neonatal cholestasis. During infancy, recurrent pneumonia, malabsorption syndrome, hypoproteinemia, vitamin E deficiency, zinc deficiency. Toddlers, pneumonia, rectal prolapse, failure to thrive. And school going is recurrent pneumonia, failure to thrive, bronchitis. Adolescents, it may be failure to thrive, LRTI, steatoria, delayed puberty, and allergic bronchopulmonary aspergillosis. In adults, chronic lung diseases, sterility, diabetes, liver disease. A child being treated as asthma and develops clubbing, that is one of the important clue that you should be ruling out cystic fibrosis or primary ciliary dyskinesia. And you make a diagnosis by doing a sweat chloride, which is, if it is more than 60 milliequivalent, then it suggests that it is a cystic fibrosis. That is a gold standard. Other alternative is to document 2 mutations, or you can do a abnormal nasal transmembrane potential difference that is limited to a research laboratory, or now we are encouraging aquagenic wrinkling as a screening test, not a diagnostic test. A little bit about primary ciliary dyskinesia, when to suspect. So this is one of the emerging illness which may be responsible for wet cough and repeated respiratory infection. Persistent wet cough since infancy or early childhood, nasal discharge, sinusitis, and history of respiratory difficulty at birth or unusual course of transient tachypnea of newborn. Then you will consider that whether I'm dealing with primary ciliary dyskinesia. And how you investigate clinical features, and then you can use the screening test as a screening test by doing a nasal NO. Just purpose of showing this nasal NO is that it is possible in an office practice, and it may act as a screening tool. It doesn't require a significant skill. That's why I'm showing this, that it can be done in an office practice. And then other thing is high-speed video microscopy. You can see here that you take a nasal brush and you can see that these are the cilia in a normal nasal mucosa, which is having a beating, which is very clearly seen, and it can be done even in an office practice because it doesn't require too much of a infrastructure. Similarly, if you see this one, this is a case of primary ciliary dyskinesia. You are not able to see any movements over here as compared to the previous this thing. So it suggests that there is a immotile cilia. Then other thing is EM of a nasal scraping. So this is just to tell you that the EM may be abnormal in 60 to 70%, and you may be able to identify these abnormalities. And then of course mutation analysis. So this way, how we make a diagnosis of primary ciliary dyskinesia. Then what is the role of investigation? So common investigation, as it was discussed, X-ray. So if you see something like this, there is a hyperinflation in this X-ray, shift of mediastinum towards the left side. And then you can see that this was a suspected foreign body, and this is after removing the foreign body. So it is important to take a good history if a child is having a persistent cough, whether it was a sudden onset, whether it is persisting. And in majority of the patients, 75% of the time, you may be able to get history suggestive of foreign body aspiration. So if you find something like this in X-ray, in which there is a hyperinflation, there is a peribronchial thickening, there is a ring shadows, then it suggests that it is bronchiectasis. And in those situations, you will think of immune deficiency responsible for repeated infection, cystic fibrosis, ciliary dyskinesia, repeated aspiration, and so on. If you find there is a situs inversus, then you think of primary ciliary dyskinesia. And if X-ray is normal, then and it is a troublesome cough, in those situations, you will think of further evaluation. So what is the other investigation? It is a flexible bronchoscopy. Just to give you an idea that how bronchoscopy may help you. Say, now we know that there may be some structural abnormality in the upper way. It may be there in the lower airway. It may be there in the airways. So this is a bronchoscope in the pharynx, and you are able to see a cyst, which is a vallicular cyst, which may cause repeated aspiration, repeated cough, and obstructive respiratory disease. Here you can see this is a very common scene that there is a large adenoid, large tonsils, and that you can decide that yes, this child requires an investigation. This is your arytenoids, aryepiglottic folds and arytenoids. They are getting sucked during inspiration. Just to say that this is a point of care investigation which will give you a diagnosis. So this is a laryngomalacia, and you can see that whole of the aryepiglottic folds are going in. So this is just to inform you that if available and child is having cough which cannot be explained, there is some noisy breathing, go for a bronchoscopy, and that will be point of care test in which you may have a diagnosis immediately. So you can see, I'll because of time, just to give a concept that yes, bronchoscopy, how it can help. Otherwise, say this is another form of laryngomalacia. So we'll go to the next slide, and if time permits, then we can show the details of other bronchoscopic finding later on. So now we go on to a quiz in which there are two quiz. So I request Dr. Subramanya to moderate this case quiz. So I'll show you a video and just you have to show that what is the write the diagnosis in your chat box. So this is the first quiz. Your bronchoscope is in trachea.
Sir, you wanted to make it very spicy for them. Okay, you are in trachea now. What you will see?
So this is the so give the diagnosis, code diagnosis.
Yeah. Please type the diagnosis, but Kabra sir can't see the screen, so I will read out the diagnosis that you type. Any diagnosis you write, no problem.
Okay, so we are stopping
Somebody
here.
has
There is
written
another
tracheal
quiz.
web, tracheomalacia.
It can't be tracheomalacia because it is kept open. Okay, and you can see that generally you will find in a bronchoscopy trachea would have a D shape. There is a flattening of the posterior wall, and there is a D shape. So it is complete rounded, and you are not able to pass your bronchoscope. There is a no soft tissue in the posterior part. So what is this? Any other diagnosis?
Sir, somebody has told growth, stenosis.
Stenosis, okay. So it is a stenosis and secondary to something like, he's right that there is a stenosis.
Somebody has written web, vascular ring.
No, it is not vascular ring. I'll show the, if time permits, then I'll show the vascular ring, how it will appear in the bronchoscopy. But it is not suggestive of vascular ring because it should be compression from one side. So it is just for the sake of time, it is a complete tracheal ring. As tracheal rings are posteriorly, there is no tracheal ring. So it is a complete tracheal ring. Okay, so now this is another just for sake of fun. So this is a quiz for second case. Trachea, this bronchoscope is just above the carina. You are able to see the right and left main bronchus, and in between there is something more. So this is probably more easy.
Yeah, you can almost see like nose, but at the level of philtrum, did you observe what was there? Somebody has written TEF.
Yes, he's right. He's right. So it is TEF.
TEF, sinus.
So it is TEF. You can say that it is it may be communicating with the esophagus or something. Okay. So this was quiz. Now we go on to the clinical pulse. Absence of cough during sleep indicates likelihood of cough, and it requires a counseling rather than just sending the child with and no prescription of the medication. Cough is present less than 3 months, especially if spasmodic, requires consideration of pertussis syndrome. Cough in infants with feeding warrants video-assisted swallow studies. And cough presenting since neonatal period and history of TTNB, transient tachypnea of newborn, chronic otitis media warrants investigation for primary ciliary dyskinesia. Suggestion of cough after a short course of inhaled corticosteroid, it suggests strongly that we are dealing with asthma, manage it with asthma. Failure to stop cough with an oral corticosteroid or inhaled corticosteroid, then it requires further evaluation. So now we go on to the recurrent cough. Okay, so what is recurrence? Recurrence, as Subramanya has already said, it has there is suggestion of cough and there is a recurrence. Okay, so what should be the diagnostic approach? Recurrent cough in a normal child. Say one is nursery school syndrome and age-related problem. So we'll discuss what is this nursery school cough syndrome. Then recurrent cough in an abnormal child, say not growing well, associated symptoms. In that case, we have certain set of causes and that needs to be investigated. It may be asthma, it may be a other problem like a chronic cough. So what we do, if a child is presented with recurrent cough, commonest would be infection like upper respiratory, like there is no recurrence of no lower respiratory problem, no breathlessness, then reassurance is required. If LRTI as indicated by tachypnea, difficulty in breathing, it needs evaluation, even if it is a one episode. If there is allergic evidence in form of allergic rhinitis, asthma, hypersensitivity, pneumonitis, these are the causes. Associated with these, it may be asthma, and less than 5 years, then this is entirely a separate group of under 5 wheezers. And then it may be aspiration syndrome. We'll be discussing some details. And then other causes like postnasal drip, symptomatic cherry malformation, and pulmonary hemosiderosis. So causes again it is same as we have already seen. So we will go to the straight to the risk factors. What are the risk factors which predispose a patient for recurrent episodes of cough? A child who has not received exclusive breastfeeding, getting a bottle feed, parental smoking, firewood burning or biomass burning, daycare admission, pollution, and malnutrition. So now let us see recurrent infections. It may be upper respiratory, it may be a lower respiratory. So recurrent URTI is common in early infancy, average 6 to 8 episodes per year, decrease with age, again increases when started going to school or crèche. It is benign in nature and subsides by 5 years of age. Parental reassurance and counseling is the important thing, and soothing agents like honey, tulsi, ginger, frequent sips of warm water. There are no evidence, as someone has written that even Dr. Hema suggested that there are no randomized control trial, but these are considered to be innocuous, and you can keep counsel the family that it may help a little bit, less likely to create a trouble for the child. Specifically, if you are giving above age of 1 year honey, tulsi, ginger, and so on. Preschool syndrome or daycare syndrome. Early placement in childhood in these child care facility, repeated viral infection, and one merges into the other. That's why parents may say that the child is always sick after starting going to school. Average 6 to 8 infections in first year, usually the first child. No response to bronchodilator, inhaled corticosteroid, montelukast, or cough syrup. No response to bronchodilators. And careful history and normal examination finding is the key. And assure family, to assure parents that those who have a nursery school syndrome have less likely to have a repeated URI by 5 to 6 years. Soothing agents, again, the same thing. And if associated wheezing, then bronchodilators can be given. When to investigate? As we are saying, these are benign things, may recur, may not recur. So one is, if there are extra respiratory symptoms, if there is a significant, if there is a failure to thrive, marked chronic upper respiratory symptoms like snoring, rhinitis, sinusitis, symptoms from first day of life, unusual onset, age of onset. Episodes are severe, persistent, unusual pathogens, and recurrent. If any of these things are there, we need to investigate them further. Chronic moist cough or sputum production, we have already discussed. Feeding problems, aspirations, and continuous unremitting or worsening symptoms. All these require further investigation as we have discussed various causes. So first and foremost is how we approach. Observe for nature of cough during examination. As you had seen even in the role playing, that you are seeing the child and you are trying to elicit the cough. What is the nature of this cough? And Subramania has made it very clear that what are various types of cough. And induced cough reflex by maximal breath followed by the repeated exhalation, and child who coughs several times a minute, it is a habit cough. Then clue from associated feature. Diffuse wheezing, think of asthma. Localized breathing, consider foreign body, external compression, bronchomalacia. Chest pain, asthma, pleuritis. Failure to thrive, immunocompromised host, cystic fibrosis. Feeding difficulty, aspiration, immune deficiency, atypical and typical LRTI, neuromuscular abnormality. These are the other things, like a child may be having a subtle problem in the throat and then having this problem, or it may be a generalized disease of a neuromuscular problem. So basic investigations has already been discussed, but just to highlight that if there is a microcytic hypochromic anemia, it may be suggestive of recurrent pulmonary hemorrhage if a child is having a recurrent cough. If eosinophilia, consider allergic disease. If X-ray showing infiltrates, as it has already been discussed, may consider various diseases depending on the type of abnormality. And what is the basic investigation? Sputum that was discussed earlier, we re-emphasize. If it is a clear and mucoid, consider allergic reaction. Purulent indicates RTI. Excessive purulent sputum, bronchiectasis. Malodorous sputum, anaerobic infection. Alveolar macrophages or neutrophils, it is pneumonia. Eosinophilia, asthma. And if there are hemocytin-laden macrophages, it may be pulmonary hemorrhage. If it is lipid-laden macrophages, it is a recurrent aspiration, specifically in young children, infants. In advanced investigation, as we have seen, ciliary morphology, nasal endoscopy, bronchoscopy, immunological evaluation, allergic evaluation, and esophagogram. That we have already discussed, and you know where to get these tests, when to do these tests. And if there is a LRTI, this needs early evaluation because delayed diagnosis may increase mortality and morbidity. It may be in immunocompetent or it may be in a immunocompromised child, and it may be cardiac, it may be pulmonary or extrapulmonary. You can have an approach in a unilobular disease, say X-ray showing a repeated problem in the same area. It may be because of the narrowed airway, extended compression like lymph node, neoplasm, vascular ring, bronchial wall, bronchomalacia, laryngeal web, and stricture, endobronchial, foreign body, TB, or neoplasm. And if other cause may be congenital lung lesion like benign lung cyst, emphysema, sequestrated lobe, or focal bronchiectasis, if it is a localized. So what should be done to control this cough? Look for the cause and identify, treat it accordingly. If it is asthma, bronchodilator, inhaled steroids. If it is foreign body, get it removed. There is no fixed prescription that you will be giving it to all. If pneumonia, treat the cause. If immunodeficiency, treat accordingly. If extrapulmonary cause, needs specific treatment. If it is a harassing cough, it may be that may need some cough suppression, and it was discussed that not all patients, it may be this less than 5% of the patients which may require a cough suppressions. When asthma is unlikely, early onset, neonatal onset, isolated cough with no other respiratory symptoms, chronic wet cough, absence of trigger, localized persistent monophasic wheeze, extrinsic induced dyspnea with noisy inspiration, failure to thrive, feeding difficulty, choking, clubbing, and focal persistent radiological changes. If any of these are there, don't consider it to be a asthma. And what is the management outline? All of us are very well aware about it. Inhaled corticosteroid, short-acting beta agonist, long-acting beta agonist, and it should be given at least 2 months before we say that patient is not responding. Check clinical response and improvement in lung function. LTRA are less useful. Combination of antihistaminic and LTRA to be avoided, as it has been discussed. No role of second-generation antihistaminic, no role of antibiotic, no role of cough syrup. So, cough aspiration syndrome, CS, dysphagia. These patients may have a dysphagia, disorders where muscle or of the pharynx or esophagus doesn't function properly. It may be gastroesophageal reflux disease, or it may be an anatomic disorder like cleft palate, esophageal atresia, laryngeal cleft, duodenal obstruction, or tracheoesophageal fistula. And how you will identify? There is a history of choking, coughing, or gagging while eating, weak sucking, fast or stop breathing during feeding, and hoarse cry, noisy breathing or wheezing, slight fever after eating, chest discomfort or complaints of food coming back up or feeding stuck, recurrent lung or airway infections, apnea, bradycardia or cyanosis, and excessive salivation. If any of these are there, you may say that child is aspirating repeatedly and you need to investigate X-ray, CT scan, barium swallow, fiber optic endoscopy, esophagoscopy, esophageal pH monitoring, and fiber optic bronchoscopy. All these can be decided depending on what are the pointers, what are the clues, and what is your working diagnosis. So it is not required in all the patients. Just decide from the history, examination, preliminary investigation that what is the most likely cause, and then go for these investigation. A little bit about postnasal drip. It is a drainage of secretions from nose or PNS to pharynx, throat clearing. Child continues to do a throat clearing, sensation of something dripping down the throat, which can be told by the older patients, or you do an endoscopy, nasoscopy, and trial of therapy with antihistaminic may be required in some patients. So this is all about the recurrent cough and chronic cough. So over to Dr. Dr. Vineet and Dr. Garg. I'll stop sharing here. If there is a time, I think we are already late, though I have finished in 35 minutes. But if allowed, then I can show the details of, say, 2 minutes of more bronchoscopy finding.
So please go ahead.
Okay, so I'll just go back to my slide. So you had seen this one. You had seen this one. So it is a laryngomalacia, which is involving area epiglottic folds. All these things are going in. This is whole of the epiglottis is going in. So obviously you can understand that the treatment for this condition is slightly difficult. But you should be aware that there may be and how your endoscopy, laryngoscopy, bronchoscopy will help in identification of whether it is a mild disease, moderate disease, severe disease, so that you can decide about the treatment, sending him for a surgery or just a supportive care. And then someone was saying laryngeal web. So laryngeal or tracheal valve will be like this. When it is open, glottis is open, you may be able to see a thin membranous web. So you can see that this is a subglottic stenosis. Commonly, it may be after a bronchoscope, after a endotracheal intubation and prolonged ventilation, but the child will have a dry hacking cough, and then you may be able to say that it is. And as someone was saying, tracheomalacia. This is tracheomalacia. And our patient in the earlier quiz it was rounded, and it is pliable. It is severe tracheomalacia. And you can see someone was saying that it may be a vascular ring. So it is an asymmetric narrowing with you can observe some pulsations. This may be a benign tumor of the trachea, and then this foreign body very commonly, relatively more common in a clinical practice, which may be responsible for persistent cough or repeated pneumonia. So that should be considered very carefully. And then you can see earlier we had seen this is a bronchomalacia, that your right main bronchus, anterior and posterior walls are touching to each other. Generally, it would be nice rounded structure which can be seen. So you can see this is normal anatomy, but lot of secretions. As compared to the previous case, lot of secretions, thick, viscid, ropey secretions, very difficult to clear. So it in the bronchoscopy itself, it would be clear that it is probably we are dealing with cystic fibrosis. The secretions of this PCD would be purulent and can easily be cleaned. So just to say that bronchoscopy may be a point of care test wherever it is available. Chronic cough, you are not having any pointer, and it is worth going for a flexible bronchoscopy under sedation. Thank you very much. Okay.
Yeah.
So I stop sharing and then proceed. Okay, Dr. Subramania.
So Dr. Vineet and moderators.
Thank you, sir.
Yes, sir. Thank you, Kabra, sir. Yeah, just I would like to invite Dr. Vineet Sehgal to give their comment.
We've come to heart has to take a back seat and Dr. Kabra's brain has to take over, because chronic coughs are unlike acute coughs. Usually they have a specific cause, so they need more brain, less heart. With all due apologies to Dr. Subramania. But yes, you need to differentiate between a recurrent cough and a chronic cough, because these two have different connotations. So history is important. And of course, within chronic cough, you have to look for any specific cough pointers, typically a wet cough or failure to thrive or persistent fever. And that kind of points you towards the diagnosis. And I think we'll close the session there as we are already running late. Thank you, sir. Thank you again, Dr. Kabra.
Thank you, Dr. Vineet.
Can we go to the last part of the
Yes, sir.
Today's
Yes,
session? But before we go, I will leave it to the organizers. But just if you have anything else, I will go to the summary.
If you allow me, sir, should I name the people who have given the pretest and who have scored the full marks?
No, that's fine. But I don't know. Basically, sir, what I wanted to know is how much of more time we have got. We don't know.
Actually, time is almost over, sir. I think we can take few case scenarios if anything left out, and then.
You want to take case scenarios, Shitanshu?
Yeah.
Okay. Shitanshu, you want to take case scenarios?
Have not been included here in the module. So
It's all right. No. You unmute. Now,
yeah.
question is that should we do that post test? At least can we do now before I go to conclusions?
Yes, sir.
Yes,
Can you administer that post test link as well as feedback form? Then I'll come to the end of the session called conclusions, right?
Yes, sir. Dr. Dinesh?
For the post test, we have created a nice and fun way, and we will play on the Kahoot, and we'll see who have learned a lot and who comes out first 5 or 10. So
Okay.
I'll be posting the Kahoot link. Dr. Shalini, you post the Kahoot link on the WhatsApp group. We can give 10 or 15 minutes to the audience, and we can see here also who are coming first, second, or whatever. So I'll be posting the link in the chat box also, and we'll be posting in the WhatsApp group also.
Okay,
And
done.
we'll be sharing the screen.
Now, should we take up question and answers and then summary, or summary and then question and answers? Whatever way you say, based on the time. So I'll tell the
In
summary and
this
then we'll go
15
for question and
minutes,
answers. We'll take the summary
in this
first.
15 minutes, we can take the questions also.
No, I will just
Those
tell the
15
summary.
minutes.
No, I will tell the summary of today. So it will be only 3
Okay.
or 4 slides. Then we'll go to question and answers. We'll allow all the questions. So my dear friends, this was a small attempt from us. We are not complete on every cause of the cough. It is not possible. We have covered most of the causes of the cough and most of the presentations of the cough and most of the points about the cough in a kind of approach that we can do. So please, at the end of the day, be it acute, chronic, or recurrent, cough is a protective reflex. Don't try to treat the cough, but treat the cause of the cough. It's a commonest complaint in pediatricians OPD or even in the ward. It causes anxiety amongst the parents. In acute cough, it's a symptom of disease, but not a disease by itself. Most likely, the pathology will be in the airways. Associated symptoms are very important, whether it is fever, whether it is triggered, seasonal, evening, morning. So, and whether there is weight loss, whether this child is growing well, not growing well, even whether the child is obese, isn't it? Or whether there are nasal symptoms, ear symptoms, and cough. So like that. Or let's say there is a effort, breathlessness following an exercise, triggered or otherwise, it could be even cardiac disease. So clinical evaluation is very important and mainstay of the cough. In most of the cases, investigations are not required, exceptions are chronic. Beware of red flag signs. And this is the summary of the acute cough. Cough syrups have no beneficial role. I don't say no role. There is no benefit versus harm. So they don't benefit for the given doses that you would give. And most of us do not know the dose. See, try to understand. So there is a dextromethorphan not recommended below 6 months, 6 years of age. How can you give dose and combinations, especially bronchodilator with a bronchosuppressant? So things like that should be avoided. Home remedies are overhyped than the actual benefit that they have got. Parent counseling is the most important stay. In chronic cough, history and examination is most important. There are two things that come out in chronic cough. Is it specific or non-specific? If it is specific, treat the etiology, say tuberculosis, say bronchiectasis, etc. Understand? Cystic fibrosis, like that. If it is non-specific but just continuously coughing, no reason at all by investigations and history, but only cough is there, then evaluate the environment, growth, and child's activity. If it is fine, just wait and watch. 80% of the non-specific coughs also resolve. This is just like chronic pain abdomen in children. No, don't do anything but they resolve, isn't it? So sometimes you may have to do chest X-ray and spirometry to see if you have missed anything. When it is non-specific cough, if you discuss with the parents, if it is chronic, if it is wet cough, you should give trial of antibiotics for 2 weeks. If it is dry cough but non-specific, you may try an ICS, and if it responds, then it is probably fitting into cough variant asthma or allergic in nature, and trial is for 3 months or 12 weeks with budesonide 100 micrograms twice daily. Always follow pediatric specific cough management protocols or algorithms. There, when you see, Google it out, you may find many adult references. Please be careful. Take a proper history. Look for, when you say specific cough, there will be specific cough pointers. See, like cough in bouts, um, I would say partisoid nature, so on and so forth. Did you understand my point? There'll be some pointer, clubbing, so on. So you please look for the pointers, nocturnal, like that. For children with cough and at risk of TB, you please have to investigate for TB. For want of completion at 2 to 2.5 to 3 hours, we have not discussed anything related to cough and TB, because that itself is a separate disease and chapter by itself, and so therefore we have restricted ourselves to non-tubercular cough. So please pardon us for not making but in TB, let me tell you with one line, the other symptoms are as prominent as cough. Only cough cannot be TB. Flexible bronchoscopy, BAL, and assessment can help in evaluation. Additional tests should be individualized. So it's a copyright from Indian Academy of Pediatrics. We have shared already. Whoever does the WhatsApp to me, I will share the PDF with you. That is because I can't mail to everyone. It is easy to forward PDF to you. Please do not use it, misuse it. Use it for academic purposes. Don't share it to the friends who have not attended the TOT. They don't understand anything from a PPT. Make them attend this module. You can conduct a module. I'll give you the slides. But later you send the slides to them. Keep it with you for your reading. And I want all of you, there are nearly 200 plus members. All of you should become members of IAP respiratory chapter. So over to Mittal couple to see that everybody gets into respiratory chapter. And so thank you very much. How to conduct the cough module, you can WhatsApp to me, and then we will guide you to conduct this thing. Post test, question bank, everything I will not share now. I will leave it to the organizers from Indian Academy of Pediatrics respiratory chapter. We are very thankful to both Mrs. and Mr. Mittal. So thank you very much. And I would also thank all my co-faculties. We might have given few more slides, less slides, so we had to balance somewhere. Hima, Shitanshu, Dr. Kabra sir, thank you so much. And I hope one feedback we want from all of you. If you like it, just type, yeah, we liked it. Otherwise, if you have criticism, please post it to me. We will take it. Criticism means it should be good. Yeah, we will always welcome you for any criticism, like any corrections in any part of the slide. We are also learning. We'll be very happy to take it up. And if there are any questions, any one of the panelists, we will answer. Over to you, sir. Over to the chairpersons and organizers.
Dr. Vineet sir, Dr. Arun sir, there. So this post test is basically, it's a fun way, sir. I request Dr. Subramaniam sir, you also play this. And we at IAP North Delhi, we found some kind of innovative ways to make it fun learning and fun things. So I hope everybody will like this. This is something different. You will find something different.
Yes, sir. There was one question which has come repeatedly. Dr. Premlata wants to know what about GE reflex. So anybody wants to take up? Hima?
So GE reflex is basically gastroesophageal reflex. Normally in small children preterms, we have this as a physiological, but it becomes pathological once we think about a gastroesophageal reflux disease, when there are micro aspirations and lung can be affected. So that is a gastroesophageal reflux disease, what we were talking about.
Any other questions are there? Then I think we'll take up. Can you stop sharing the screen, sir?
Okay, sir.
So that we can see the chat box. Yeah. Role of codeine for severe and critical pertussis, there is no role. Mild suppressant, if you want to try, see, you have to weigh the benefits. And by the time the codeine works, see, I'll tell you how the cough syrups don't help you. All of you remember that you have sedated your children for MRI, CT scan, and short procedures. You might have given, Midzolam or even Compose or whatever. But when you want a child to sleep, it will not sleep, and you are desperate in doubling the dose or giving 1.5 times. Have you all experienced this in day-to-day practice, even pedichlorine for that matter? So try to understand, when you want a child won't sleep. Same way, when you want to stop the cough, it won't stop. So somebody was asking about all the syrups, so that is the answer. So it seems things are fine. If there are any questions, we are ready to take up. Still, if there are questions, please ask. Mucolytics don't help unless there is mucus. And I'll tell you, children are like, they don't have a matured epithelium for them to, all these pharmacological agents to act well. More so in newborns and young infants. Did you understand my point? The mucociliary epithelium, everything has to mature. Then only those drugs will work. In specific cases, to treat the cough, you have to treat by the disease protocol. Let's say cystic fibrosis, TB. You have to go by the disease protocol, not by the cough protocol. Cough is only part of the disease.
Dr. Subra, can I have a word
Yeah,
from
please,
you?
sir. Vasudev, sir, you are welcome.
I just want to find out, a lot of my patients who are nephrotic, and they are edematous initially, and later on also during relapse also, they have a lot of coughing, and when we auscultate them, most of them are wheezing. And there's no previous history that this child had been wheezing earlier. He's now 5 years, 6 years when he had nephrotic. Earlier, there is no history, but off and on, I see that they start having wheezing whenever they have some edema and proteinuria. And I don't know whether it's related
Sir,
to...
no, I'll dissect this case, sir. Actually, I would compliment you for this excellent bridging between, nephro and respiratory. I'll tell you what has happened. This particular patient has come to you with a nephrotic presentation, or I would say relapse, and he's coughing now. Actually, the illness is not when the cough starts. The illness has started much earlier. Are you getting my point, sir? The illness has started much earlier, and that URTI or LRTI could be a trigger for the nephrotic rather than other way around, that the nephrotic has got a cough. So most of the times, sir, Vasudev sir, do you agree that infections trigger?
Even if they are well, otherwise there is no trigger, there is no fever, but whenever they have some edema, they have wheezing. I was wondering whether the incidence of asthma or wheezing is more in these children. Maybe nephrotic also we sometimes consider as maybe one of the allergic forms, and wheezing also as one of the allergic manifestation. Is there some correlation? I have not been able to find out, but I have talked to a lot of pediatricians.
But all that I can tell you right now is asthma is not an airway disease, it's an immunological disease, and nephrotic is not a renal disease and an immunological disease. And this connect can be done by neither a nephrologist nor a pulmonologist, somebody immunologist. If there is anybody, they can comment.
I think it can be done jointly, because I asked a lot of pediatricians and they also feel that these nephrotics the wheezers in nephrotics is much more than the common children.
Maybe, sir, excellent observation. I compliment you for that. Somebody is there in this group who is an immunologist. Please raise your hands. I think we can allow you for comments also. It's fantastic point. If there is anybody, please put it in the chat box. The organizers can allow them.
How do these children get relief when we even put them on bronchodilator, sometimes nebulizer? They do not respond. But when I start them on diuretics and the edema starts decreasing and the child is more near normal, the cough automatically disappears.
That is fine. That I know. Interstitial edema in the lungs can cause cough, and the cause of cough is J receptors in the interstitium. There are cough receptors in the interstitium called J receptors. They act by stretch reflex.
But then is the wheezing also affected by these stretch reflex?
No, wheezing here is like cardiac asthma, not related to airways.
Because we
have got cardiac asthma. I think that is the old time. Myself and you, when you were in colleges, we were taught cardiac asthma. You remember, sir? Nowadays, we don't use that word. I'm just, for simplification, I use that word.
So that's my observation, and all the respiratory specialists are here. So I thought I'll put my question and maybe I get some answer to that.
But sir, from our end, there is no hesitation to use bronchodilator in anyone, because whatever benefit it will do. Even when there is no bronchospasm also, bronchodilators do help because there is salbutamol. And the normally in normal population also 11% of the normal population can have a bronchoconstriction. What I meant was, if I take 100 normal children in a school and give salbutamol to them, and if I do PFT, 11% of them improve. They need not have asthma. It is physiological. Something like airways or touch me not in them, touch me not plant. They open up. So this secondary benefit one can get in any disease, and that should be always given as a benefit of doubt to the patient. So therefore we say always, thumb rule is that if the bronchodilators help, continue. If the bronchodilators do not help, then it is not a dynamic airway obstruction, it is a fixed airway obstruction.
Right.
Any other questions? The role of some strange names I'm hearing, so we don't use them. Ambroxol, no role. Ambroxol is added to increase the cost of cough syrup. Salbutamol is 12 rupees. If you add Ambroxol, it is 75 rupees. The pharma has added Ambroxol only to come out of drug controller. Price capping, not to improve the cough. See, do you get a plain amoxicillin? Plain amoxicillin is, let's say, 4 rupees. Then amoxicillin with lactobacillus will be 12 rupees. I think, are you understanding my point? Once the drug controller brings amoxicillin under rate cap, the pharma will add lactobacillus. And if amoxicillin with lactobacillus will come under rate control, they will add bactobacillus. I'll tell you, they will go on adding something to escape the rate control. See, that's why you will see a lot of combinations. If cefixime is there, they will add clavulanic acid only to increase the price, not to add any benefits. Okay, I think if there are no questions, I would have one word from each of the panelists, and then we'll finally wind up. I will start from here. Hema?
I hope the module was as to the expected, and it was informative for all the delegates. I think it was a very basic module, common approach, common practical pediatric approach, which we all face in the OPD, talking about acute cough, chronic cough, and the basics of cough. All inputs for improvisation of it are all welcomed, and they can be WhatsApped in the groups or to Dr. Subramaniam or to me or any of the faculty. That's it, sir.
Shitanshu, one word from you, my favorite pediatrician. You can unmute.
Thank you so much, sir. It was a great learning experience with you, Dr. Kabra, sir. And I really thank Shalini ma'am, who is my senior from BJ. Subramanian sir is also an alumni of BJ Medical College, Ahmedabad. So thank you so much for the opportunity. Thank you so much. And all the respected
I wanted to add, Dr. Sitanshu, Dr. Manish Gupta is also from BJ Medical College. He is also in panelist.
Okay.
Oh my God. So all of you are from BJ, but I am from the BJ Medical College, Pune, not Ahmedabad.
Okay.
Oh, yes, sir.
So that is the same sister branch.
No, anyway, fine, fair enough.
Yeah.
Just this is on a lighter note.
Yeah.
And for the participants, please WhatsApp to me, and my PDF is ready. In 2 seconds, you will have the PDF with you. I will type the number in the. I have already written, but I'm typing again. Please write your name, otherwise I can't save. And I don't know whether the PDF goes or not. I can save your number and then send you the PDF, please. Write your name, and you can write your mail ID. If you can't open, then what I will do is I will help you, right? So thank you very much. So I will leave it to the organizers for whatever ceremonial things they have got, vote of thanks or whatever. Please join us again and again for cough module. And many more modules are going to come. We are having advanced pneumonia module, advanced asthma module, basic asthma module, airways module, and oxygen therapy. And I wish that Delhi chapter will take launch of one of those modules at least. So from the next, this is launched elsewhere and then we have done here. So we'll do many more modules in the coming days. So be on your toes to watch for. So over to Dr. Mittal sir.
So I am now
I
sharing
just joined
the.
for inauguration and then continue to sit till the end of the module. It was excellent, and the mother and Dr. Play Subra, I think you were at your best. I enjoyed it. Thank you.
Sir, a word from a senior like you, it's very soothing. Thank you so much, sir.
So these are the results with the posters, sir. Almost 160 players played it, and correct answers were 45%. So it was really a tough one. Incorrect was 55%. And let me show the final scorers. Dr. Avinash Jha, he's given the 14 correct answer and 1 incorrect answer. Some saying MHK. I think everybody can see the results on the screen.
Not really, Dr. Dinesh, we are not able to see.
The screen sharing is not visible.
No, it is
screen
visible.
sharing is visible. Yeah.
Yeah, Avinash Jha is the first one. He completed, he gave the fastest answer. And this MHK, although he gave the all correct answer, but he was a bit slow. So that is why the Kahoot has ranked him 3. Deepti is the 4th one. This phone number 95826966614 is the 5th one. PG, they have given all the short names. 6th, Vikram, SUND. If any one of you are there, you can raise the hand and we can take you on the panel. The first 10 one, Avinash Jha is there. Dr. Shalini, can you take him on the panel? Those who are raising the hand, you can take on the panel.
Yeah.
So,
okay.
Avinash Jha has raised the hand. Harpreet Kaur is also there. Shweta Shekhar.
No, I think I'm not
So Kahoot
right now. Dr. Hema, can you share it? Can you?
Dr. Hema, can you?
I'm just trying. I'm trying to add.
So these are the things. These are the final details of the.
I think Dr. Avinash Jha was there in Palmocon also, and he won the prize in that.
Yeah, he
went. Also, no?
Yeah, he third prize, I guess so. But he's really a bright student.
Yeah, congratulations. Many congratulations, Dr. Avinash.
Who is the topper, madam?
Avinash Jha, sir.
No, he is a postgraduate?
Yes, sir. He's a postgraduate, sir.
Okay. Then we can give him complimentary respiratory chapter membership if he's a topper.
I'll forward you the name.
Should I stop the sharing now?
Yeah, you can stop the sharing.
So if you can take Dr. Avinash on panel, have anybody? Mahank is also there. Avinash. Avinash, can you join as a panelist? Yeah, Avinash is there. Kindly switch on your video. Many congratulations, Avinash.
Please unmute yourself, Dr. Avinash. So now we can hear from you.
Yeah, now you can speak.
Everyone. Am I audible?
Yes, you're audible.
Yeah.
Thank you so much, sir, and it was a
Okay.
great webinar. Especially Subramanian sir's role play was actually, it was good. Thank you so much.
No, we want you not to prescribe cough syrup, but not like the role play. Okay, Avinash?
Yes,
Done, done.
yes, surely.
So you must do that role play in your department with another student, okay?
Of course, of course,
Okay,
of
then we will
course.
be very happy. And send me the video of that. I will play that video in the next session, not our videos every time.
Okay, sir.
I want
I will WhatsApp you,
students to be
sir.
there in the limelight. Okay, please. Thank you so much.
Okay, sir.
So, with this, we are coming to the end of this beautiful session on cough, and I hope that every one of you will be more intelligent and in treating the cough. I am really thankful to Subramaniam sir and the IAP Respiratory Chapter, as well as IAP Delhi and all my colleagues, including Dr. Hema, Dr. Shalini, Dr. Manish, Dr. Arun, Dr. Richa, Dr. Lalit, Dr. Vasudev sir, of course, and Dr. Smita is always a pillar. Thank you, Dr. Shantanu, for such a wonderful role play as well as and other question and answers also. So over to Dr. Shalini, you want to say something?
I just want to thank to whole IAP National Respiratory Chapter, especially Dr. Subramaniam sir. Really, very much, I'm learning a lot from you, sir. And since I have attended the module TOT in end of September, I am really following that. I am giving a lecture to all. Whenever I get time, I used to give them a lecture on cough syrup. And I'm trying my best. And if I do right, I feel really guilty that I'm writing cough syrup, sir. I'm really thankful to you, sir. The whole team. Thank you so much, Dr. Hema, Dr. Sitanshu. Over to you, Dr. Dinesh. Thank you so much.
I also request Dr. Smita ma'am to give the final words.
Thank you very much, Dinesh, Shalini, Hema, Richa, and Arun, and Dr. Manish, all team, Delhi, North Delhi team. Dr. Subramaniam, you have taken our stage performances in medical colleges to another level. I never knew what we did on the stage we can use like this. Wonderful way to process the knowledge on everybody brain and to make everybody understand what you are saying, what everybody was saying is really means a lot, and it has to be impressed upon the people who are non-medico, and they must understand that something natural process exists sometimes.
Yeah.
Okay. Thank you very much, sir.
Thank
This
you.
wonderful session. I'm a pediatric cardiologist. And
Oh my God, so
I
nice.
have learned so much. Thank you.
So you could be jealous of us that some cardiology points are not there. You can send it to me wherever we have missed out something from
Sure,
our
sir.
cardiology and cardiorespiratory is brothers and sisters, you know. If lungs are not healthy, heart starts asking, and if heart is not healthy, lung starts telling, you know, your heart
Sir,
is
that
not
is what I was in morning. I was just having a patient with VSD, and we were talking. Patient presented with cough. I was
Correct.
telling registrar it cannot be CHF which is causing cough. Cough is primarily because of some lung issue precipitating the cardiac this thing. So this is very important because shunt lesion, they have heart failure, but they don't have cough.
Correct.
But
Excellent point.
if there is a pulmonary edema and you have a back pressure,
The receptors are less there.
then you
Yeah.
may have cough, but
So
not
just end in a
entirely
light
over.
note. If both of us are in trouble, then Dr. Vasudev has to come.
Thank you, sir. Very nice to see you and listen you. Wonderful. Thank you, Dinesh, for calling me. Thank you.
I also request Dr. Manish if he's there to say something, sir, because at the time of when you are a chairperson, the sound was not working. You're there, sir?
Yeah.
I'm there. Actually, today is my father's birthday, so a lot of guests are gathered here. So it was really a very nice session, Dr. Subramaniam, Dr. Hema, Dr. Shitanshu. And the best part was of the webinar was the way you conducted it, sir. You all three And I mean, you made the people part of it. The way you conducted the interaction, you started with why, hatch, and you started with role play. I really like that part. In fact, we would like to learn and incorporate this in our webinars, sir. And sir, there is huge fan following for you in the chat box. You can say there are 20 people recommending you for a lot of role plays, sir.
Oh, that's fine. No, I thought they wanted me to shift to Delhi.
And sir, excellent module and excellent content, sir. I must congratulate the whole IAP respiratory team, IAP North Delhi, Dr. Dinesh and Dr. Shalini. They have cracked all the records, I think. So they have done excellent work. And sir, thanks for all the learning, sir. Thanks a lot.
Thank you.
That's all, sir.
So with these remarks, I thank you everyone. And I invite to our next CME, that is on the pediatric endocrinology, that will begin from the 15th of this month to 18th of this month. It will be a 4-day conference, and it will be every day. There will be 3-hour teaching, and we will try to involve as much as pediatric endocrinology, especially for the young pediatrician is concerned. So I invite all of you, and with this, thank you very much.
And all of